Mr. Mingo. No, you're not. No.
Is that better?
That's better. That's
okay.
it.
The National Pharmacy Association, or NPA, is grateful for its designation as a core participant in Module 4 of the inquiry. The inquiry will be aware of the NPA's role and interests from its participation in Module 3. But for the benefit of those core participants not involved in that module, and in brief, the NPA is a representative voice of independent community pharmacies across the UK. That is family-owned and run independent pharmacies through to small to medium-sized regional chains. An estimated 50,000 people, including around 15,000 pharmacists, work in the NPA's 6,000 member pharmacies. Community pharmacy is an integral part of the NHS and primary care networks, and it plays a crucial role in maintaining and improving the health of the communities it serves. Community pharmacies are embedded within their communities, and 96% of the population can reach their local pharmacy within 20 minutes. Community pharmacy played a vital role in the delivery of the Covid-19 vaccination programme, and community pharmacists and their teams have delivered over 42 million Covid-19 vaccinations. This opening statement seeks to highlight the NPA's significant role and interest in the delivery of the Covid-19 vaccinations across the UK by recognising the success of the programme, but also identifying a number of areas for improvement. The Covid-19 vaccination programme in the UK operated at an unprecedented pace, scale and complexity, and was one of the success stories of the pandemic. Community pharmacy played a significant role in the delivery of the programme, which increased over time as the value of the contribution of community pharmacy was recognised. One community pharmacist in Macclesfield highlighted the importance of the programme and the commitment shown by community pharmacy teams in delivering it. To quote, "I've been a pharmacist for 38 years, and I can say the day when my pharmacy became one of the very first in the country to administer the Covid-19 vaccine was the biggest day of my career. It's been quite emotional at times for our patients. Some people have not been out of their homes since last March. They are hesitant to be outside and are not used to seeing people. They see being vaccinated as the start of the end of this grim existence. A lot of work has been required of the team here, but we are very excited about it. Everyone here is part of something special. We're proud and honoured to be involved in this national effort to help protect the population of the country and hopefully return us all to some form of normality." The NPA's Vice Chair, Olivier Picard, has produced a witness statement for the inquiry, which is disclosed at INQ 000474318. And within which is an account of his experience of setting up a vaccination centre, reflecting the collaboration between community pharmacy teams and other healthcare workers. Mr. Picard has also highlighted the vital role played by volunteers in supporting the vaccination programme within local communities, remarking, "I have never seen a community come together like this before, nor have I ever been involved in anything that meant so much to so many people at the same time." The NPA respectfully asks the inquiry to consider and recognise the invaluable contribution of volunteers to the success of the vaccination programme. My Lady, the NPA acknowledges that the Covid-19 vaccination programme was an emergency response, that the lessons were learnt and improvements implemented throughout the programme, and that overwhelmingly it is one of the success stories of the pandemic. Nevertheless, it is important to reflect on areas that could have been done better, and the NPA asks the inquiry to reflect on the following points in its consideration of how delivery of a vaccination programme could be improved in the future. First, the need for effective planning and the involvement of community pharmacy from the outset. Community pharmacy should have been consulted and involved earlier in the planning process, particularly given its years of experience and expertise in delivering annual flu vaccinations, and given the reach and resources of the approximately 13,000 community pharmacies embedded in communities across the UK. Instead, community pharmacy was initially given a gap in service role, which failed to utilise their experience, expertise and resource. The NPA considers that the decision to limit the role of community pharmacy to gap in service provision, or where there was a need for additional capacity, was a missed opportunity to ensure wider public access to vaccinations through the extensive national community pharmacy network, particularly as some patients were being asked to travel considerable distances to receive a vaccine. Vaccination centres provide a capacity to deliver high volumes of vaccinations in dense population areas with good transport links, and this was an important part of the programme. But so too was the ability to provide vaccinations within communities and to reach underserved communities. This balance needs to be better delivered in the future. The ability of community pharmacy to participate in the initial phases of the vaccination delivery was significantly limited by certain requirements of programme participation, which were unnecessary and arbitrary. For example, participation in Phase 1 in England required the administration of at least 1,000 vaccination doses per week and opening hours of between 8 a.m. and 8 p.m. 7 days a week. This unnecessarily prevented the participation of smaller pharmacies who did not have the physical space to deliver this volume of vaccinations or the staffing capacity to administer them. Largely because of these restrictions, there were only 6 community pharmacy-led contributors to the first wave of Phase 1 of the programme. In January 2021, the NPA's chief executive wrote to the chair of NHS England, pointing out that community pharmacy was being underutilised and that pharmacies can deliver so much more for the NHS if the potential for the network is recognised. As requirements were relaxed, community pharmacy was able to make a much broader and more effective contribution. The role of community pharmacy increased throughout phases 1 and 2, and on the 3rd of June 2021, the Covid-19 vaccination minister announced that over 500 community pharmacies had delivered over 5 million vaccines in England. This contribution continued to increase throughout the pandemic, and by 2023, 24% of all vaccinations had been provided by community pharmacy. Other challenges faced by community pharmacy in participating in the vaccination programme from the outset included the different storage requirements for vaccines and the already stretched community pharmacy services as a result of the impact of the pandemic. The second point is the need to improve operational delivery of the vaccination booking system. 2 booking systems were utilised to make vaccination appointments. The national booking system was used by community pharmacy and vaccination centres, and a separate system, AccuRx, was often used by general practice. The NPA's view is that having a dual booking system was inefficient and wasteful. The 2 systems did not share information, causing duplicate bookings, which resulted in missed appointments and adversely impacted efficiency. This situation would have been worse but for the flexibility and resourcefulness of frontline healthcare workers in sharing and sourcing unused vaccination supplies. Other challenges for community pharmacy related to PPE provision, high volumes of administration and bureaucracy, and poor communications, with vaccinators sometimes finding out about changes they needed to implement the next day on the evening news. Thirdly, addressing barriers to uptake. The NPA believes that the significance of vaccine hesitancy as an issue was not appreciated early enough, and there was a delay in recognising the positive role that community pharmacy was able to play in addressing this issue. Approximately 50% of the NPA's membership are from ethnic minority backgrounds, which is reflected in the composition of the NPA's board. The role of community pharmacies as trusted healthcare professionals at the heart of their communities means they are ideally placed to respond to the needs and concerns of their patients and to address health inequalities and vaccine hesitancy within communities. Community pharmacies play a particularly important role in deprived communities, which often have less access to other healthcare services. Over a third of the vaccinations provided by community pharmacy were delivered in the most deprived communities in the country. On the 7th of January 2021, the NPA convened a ministerial roundtable with the Minister for Equalities, the Minister for Vaccine Deployment and the Pharmacy Minister, about reaching out to patients and communities who might otherwise miss out on vital care, such as the Covid-19 vaccine, and to discuss how community pharmacy could help promote uptake of the Covid-19 vaccine, including how the high levels of trust in local pharmacists could be an important factor in overcoming doubts and misapprehensions about vaccination. In addition, with Doctors of the World and NHS England, the MPA launched a toolkit for delivering an open access vaccination clinic to provide vaccinations for hard-to-reach groups, including asylum seekers and the homeless, and to promote a continuing focus on addressing vaccine hesitancy and reducing health inequalities more broadly. In Wales, community pharmacy was specifically engaged to address vaccine hesitancy. In Northern Ireland, community pharmacy was similarly engaged to increase access to Covid-19 vaccines for priority groups and in areas where vaccine uptake was lower than the regional average. And in Scotland, community pharmacies were commissioned to deliver vaccinations in more remote areas. The MPA acknowledges that lessons were learned over the course of the programme and that governments quite quickly came to recognise and utilise the strength of the community pharmacy network. However, these issues could have been better anticipated, and this should be key learning for the future. Fourthly, the importance of utilising existing resources and expertise. The MPA considers that it is more effective and efficient to build and deliver healthcare services, such as a vaccination programme, through existing health infrastructure, which includes the extensive community pharmacy network. The inquiry is invited to examine and consider whether the creation of mass vaccination centres was a further example of a broader tendency to overlook existing NHS resource and expertise in favour of the creation of expensive temporary systems and services with little lasting utility. Finally, reducing the unrealistic expectations on healthcare workers and managing the impact on them. The inquiry is taking account of the impact of the pandemic on healthcare workers within Module 3, but the MPA suggests it will also be helpful to reflect on these impacts within Module 4. Healthcare workers who are already working in a system stretched to breaking point by the pandemic provided crucial vaccination services on top of existing commitments, many working almost continuously with little sleep or time to spend with their families. Feedback from an MPA member reflected the following. This has consumed my life, from hours spent setting up, learning IT systems, training staff, taking on volunteers, then dealing with the ever-changing vaccination programme, the weekly Zoom calls, the constant stream of emails with updates that you need to read and action. The list goes on. The second biggest enabler is my own team, who have stepped up to literally double the ask of the day job. We have vaccinated and run the pharmacy without compromising any of the pharmaceutical services that we provide. I can only hope that if this is rolled out as a business as usual, it will be easier to put in place and operate. Notwithstanding its success, this is not a safe or sustainable model for the delivery of future vaccination programmes. In conclusion, my lady, the MPA is proud of the contribution its members made in delivering tens of millions of Covid-19 vaccines, whilst continuing to deliver the core role of pharmaceutical service provision. The importance of vaccination to the healthcare system continues to grow, and the experience of the pandemic demonstrates that community pharmacy can play an expanded role in this area, drawing on the network's accessibility and ability to reach communities that often find it harder to receive health services. Thank you.
Thank you very much indeed, Mr. Menga. Very grateful. Ms. Drysdale, KC. You're there, right.
Good morning, my lady. Can you hear me?
I can, thank you.
I appear for the Scottish Government with my juniors Ian Halliday and Kenneth Young. The aim of the Covid-19 vaccination programme in Scotland was to save lives and to protect against ill health. The early rollout of the vaccine programme avoided deaths. A World Health Organization study found that between December 2020 and November 2021, an estimated 22,138 deaths were avoided because of the COVID-19 vaccination programme in Scotland. The relationship between the UK government and the Scottish government was at its best on the issue of vaccines. The Scottish government engaged both directly and through Four Nations partners as part of UK-wide pandemic preparedness and resilience measures. There were regular and candid discussions between officials and ministers about the planning and deployment of the COVID-19 vaccine. This included sharing of challenges and advice on how to address them. This level of openness and cooperation was a critical element to the success of the programme in Scotland. As the pandemic progressed, the scientific understanding of the virus developed. This was an ongoing process, with work being carried out as new variants emerged to understand the differences between them. As a result, the vaccine programme had to be flexible. It had to accelerate and decelerate to meet demand. The delivery and communication strategy had to adapt quickly to consider new clinical advice. The vaccine programme was able to respond to developments in a highly dynamic way throughout the pandemic due to the hard work and dedication of Scottish Government officials and NHS partners. The Scottish Government wishes to pay tribute to all those who contributed to the development and deployment of the vaccines, not only the scientists and the health and social care staff who delivered the vaccines, but all of those involved across society. That includes the volunteers in clinical trials and the public for their often unseen contribution and their patience. Many of those who worked on the vaccine made immense personal sacrifices over a long period of time to provide a vaccine and to save lives. They demonstrated the very best of public service values, and the Scottish public owes them a great debt. It's also appropriate, my lady, to pause and remember those who suffered from very rare cases of injury or death following vaccination. And we remember all those who suffered loss during the pandemic and who lost their lives due to COVID-19. The Scottish Government is here to listen and learn to save lives in any future pandemic. It welcomes scrutiny, both from the inquiry, but also from Scottish Covid Bereaved, the Scottish Vaccine Injury Group, and all core participants in this module on vaccines and therapeutics, so that injury is avoided and lives saved. Turning now to Scotland's role in development of the vaccines. The development of the vaccines, trials to enable their use, and the vaccine damage payment scheme were led by the UK government. Scotland was not responsible for the development of vaccines. Regulation of medicines and vaccines are a reserved matter under the Scotland Act 1998. The vaccine damage payment scheme is also reserved. The Scottish Government liaised with the UK Government on these issues and was kept informed of progress. The development of COVID-19 vaccines was the responsibility of pharmaceutical manufacturers and was led by a UK Government vaccine task force. It was a UK body with no Scottish ministerial representation. Decisions on vaccine supply contracts and investment in manufacturing were taken by UK Government ministers. An agency agreement was developed between the UK and Scottish governments in August 2020 to allow the UK Vaccine Task Force to purchase vaccine stocks on behalf of the Scottish Government. This was agreed on the basis that Scotland's percentage share of the vaccines would be based on population, that is, based on the Barnett formula. The approach taken across the Four Nations was pragmatic. Moving on to public messaging in Scotland about the vaccine. Responding to the pandemic represented a communications challenge. The pandemic itself was dynamic, and misinformation and disinformation were disseminated on social media. The Scottish Government recognised that the way to counter this was to provide transparent information to the public. In the initial phases of the pandemic, messages were aimed at the wider population, a national call for action. The later phases of the programme, with a more complex offer, called for a more nuanced approach. These stages were comprised of messages targeted at discrete cohorts by age, occupation, or characteristic. Communications focused on each cohort as they were being invited forward for vaccination, delivering and tailoring messages as appropriate for each audience. A key element was the use of blue envelopes for appointment letters to ensure that they were easily recognisable. And the Scottish Government reviewed the effectiveness of public messaging by commissioning weekly polling. It was recognised that while many people obtained information online using NHS Inform, there would be those who did not. Public messaging relating to vaccines was delivered via a national door drop. Advertising campaigns used TV, radio, press, digital, and out-of-home formats, such as billboards on bus shelters. The National Vaccination Helpline provided information. Trusted senior voices were deployed to deliver information about vaccine safety in media appearances and at the First Minister's daily briefings. The cornerstones of the Scottish Government's communication strategy were accuracy, honesty, and openness. Messaging was revised continuously when new information and data was received. This was always transparent. Turning now to delivery of the vaccine, Scotland had a clear policy position on vaccination delivery following a human rights-based approach, guided by the Joint Committee on Vaccination and Immunisation, JCVI. This was set out and agreed to by the Scottish Cabinet from the start of the programme. Scotland was well prepared to vaccinate the population promptly due to the structure of the NHS in Scotland, established distribution routes through NHS National Services Scotland, NSS, and a track record of openness to vaccination among the Scottish population. There was already a well-established flu vaccination programme being delivered by health boards, and the necessary infrastructure was already in place. The Scottish Government developed a flu vaccine, Covid-19 vaccine programme to administer the Covid-19 vaccine alongside the flu vaccine. In February 2021, considering the significant emerging demands, a separate vaccinations directorate was established within the Scottish Government. The Scottish Government was keen to ensure that its approach was aligned, if possible, across the four nations on the delivery timetable and cohort prioritisation. The four nations worked together to ensure that the first dose of the vaccine was administered on the same day in each of the four nations on the 8th of December 2020. Where there were differences in approach, this was usually due to Scotland's different infrastructure and geography. Scotland's vaccine delivery programme was Health Board-led. This model of vaccine delivery allowed Scotland to co-administer the Covid-19 vaccines alongside the winter flu vaccine from 2021 using mass vaccine clinics. Critically, the more limited use of GPs and community pharmacists to deliver the vaccine in Scotland allowed those services to focus on supporting the wider pandemic response and delivering essential primary care services. Scotland was able to use the established distribution routes and channels and the experience and expertise of NSS. Turning now to prioritisation decisions, vaccination and immunisation policy in Scotland is based on the advice of the JCVI in liaison with the Chief Medical Officer, as it is in each of the four nations. JCVI advice is not legally binding in Scotland, but was generally followed, except where deviation was necessary to meet the needs of the Scottish population. Vaccinating island communities in line with the JCVI priorities would have meant frequent reliance on small quantities of vaccine with multiple trips to remote destinations. Rural health boards were able instead to vaccinate across cohorts, sometimes out of priority order, where it would make operational sense. Scotland also adopted a slightly different approach to the vaccination of unpaid carers, prisoners and prison staff, and people with learning disabilities. The Scottish Government expanded JCVI Priority Group 6 to include people with mild or moderate learning disabilities to ensure that, in the absence of a learning disability register in Scotland, no one was excluded. Another difference was that the Scottish Government took the decision to vaccinate care home staff at the same time as care home residents. This led to higher uptake among care home workers in Scotland. Moving now to barriers to uptake. The Scottish Government recognises that there were barriers to uptake for vulnerable and at-risk groups across the UK. It responded to challenges in vaccine uptake through inclusive delivery, tailored communications, and working with partners through the Scottish Vaccine Inclusive Steering Group. There was lower uptake in the most deprived areas and from those in certain minority ethnic communities. An inclusive framework was developed. There were health board inclusion plans with assertive outreach and clinics in suitable community locations. Funding was delivered through Black and ethnic minority infrastructure in Scotland. There was the introduction of an ethnicity data collection and the National Contact Centre as an alternative to digital. The Scottish Government undertook extensive work to address concerns around vaccine hesitancy, while recognising there was a very small minority who would likely refuse any offer of vaccination, irrespective of how much work was undertaken to improve vaccine confidence. Engaging with communities through local organisations was critical to understanding and addressing high levels of mistrust. The Scottish Government recognised the importance of engaging with those representing communities experiencing barriers. Finally, turning to lessons learned. Scotland's vaccination response to the pandemic has led to ample learning and experience, which may be drawn on in the case of another pandemic. The technical report on the Covid-19 pandemic, published by the UK's 4 chief medical officers, is informing the Scottish Government's future pandemic preparedness plans for vaccines and therapeutics. The Standing Committee on Pandemic Preparedness has been established as a permanent advisory group to the Scottish Government. This committee brings together scientists and technical experts to advise the Scottish Government on the future risks from pandemics and to ensure that Scotland is as well prepared as possible. The Scottish Government carefully considered mandating vaccination for health and social care workers, but ultimately decided that the Covid-19 vaccine should remain voluntary. Engagement with employers and trade unions in Scotland indicated strong opposition to the proposals of mandatory vaccination. There were possible ethical and human rights concerns arising. The Scottish Government considered the fact that some staff would still refuse to be vaccinated, even if it was made mandatory. In all the circumstances, the Scottish Government considered that it was not proportionate to mandate vaccination. It focused instead on working with health and social care employers, providers, trade unions and professional organisations to encourage uptake of the Covid-19 vaccination. A range of digital improvements were made during the pandemic, such as the introduction of a new national vaccination scheduling system with an online booking system. The Scottish Government also introduced the Vaccine Management Tool, VMT, which is used to record vaccines administered. Ethnicity data was gathered in Scotland by including a question on ethnicity within the VMT. And statistics were routinely published by Public Health Scotland and allowed both the public and decision makers to understand differences in vaccine uptake by population demographics. My lady, in conclusion, time does not allow me to address all of the topics covered in our written opening statement, which covered these and other issues in more detail. We hope that the inquiry will find this opening statement a useful insight into the vaccination programme in Scotland, as well as providing some detail as to how the Scottish Government handled specific aspects of that programme. There are opportunities for improvement that should be taken in preparation for future pandemics. The Scottish Government repeats its commitment to the inquiry and to learning of ways in which lives can be saved and injury avoided with the use of vaccines and therapeutics in the next pandemic.
Thank you very much indeed, Mr. Drysdale. Mr. Watt.
I hope your ladyship can hear me.
Yeah, I can, thank you.
My lady, I'm here on behalf of the United Kingdom Health Security Agency, or UKHSA, as it's been called during the course of the inquiry. I may end up calling it UKHSA. You will be aware of the role of UKHSA, but for others here today, UKHSA is an executive agency of the Department for Health and Social Care and became operational during the pandemic. Its role is to protect the public from infectious diseases as well as external hazards, including biological, nuclear, and environmental threats. UKHSA brings together expertise from several predecessor organisations, including Public Health England and the Vaccine Task Force. The inquiry will, in this module, hear evidence of the impact that the successful deployment of vaccines against Covid-19 had on the direction of the pandemic. They prevented over 100,000 deaths in the United Kingdom alone, and they allowed for the relaxation of other control measures. All core participants in this module will want to assist your leadership in making practical recommendations that contribute to pandemic preparedness for the future. We must recognise that risk appetites are different during an emergency compared to peacetime, but with vaccines in mind and looking forward, UKHSA wants today to highlight 4 key capabilities which, taken as a whole, underscore the importance of maintaining appropriate baseline capabilities to allow for faster scaling in an emergency. And in so doing, I will say something about the work that UKHSA is undertaking in these areas. Of course, a number of different bodies contribute to the development and delivery of a national vaccination programme. Your leadership is already aware of the Joint Committee on Vaccination and Immunisation, an independent expert group that gives advice on immunisations and their use in the prevention of infectious disease. Second, as the independent regulator, the MHRA is the lead agency for monitoring vaccine safety and for any regulatory response to safety signals. The MHRA provides vaccine safety information to JCVI. Healthcare being a devolved responsibility, it's NHS England that's responsible for commissioning the immunisation programme in England, which is administered at local level by healthcare providers. NHS England has responsibility for the overall performance of immunisation programmes, including measures to address inequality. And finally, UKHSA. UKHSA provides the Secretariat for JCVI, but also provides expert support to NHS England, its programme implementation, ensuring that the deployment of an immunisation programme aligns with the rationale developed by JCVI and also delivering operational advice and supporting materials. UKHSA also monitors and evaluates all routine immunisation programmes. If I return to those 4 capabilities that we wish to draw to your leadership's attention, the first is sustained investment in research and development. As Counsel to the Inquiry observed yesterday, whether a vaccine can be developed in response to a novel pathogen and in what timescale is inherently uncertain. The inquiry has evidence that the time between work beginning on a vaccine for Covid-19 and the launch of a vaccination programme was unexpectedly short. But the contrasting example often given is that of HIV, for which a vaccine remains elusive. But the extent to which the UK can develop pharmaceutical countermeasures for a future pandemic will depend on continued investment in scientific research and development. The Oxford AstraZeneca vaccine was in part made possible through work funded to develop a vaccine against MERS. And that funding came from government research bodies, and the work was in progress several years before the pandemic. UKHSA itself is not a research funding body. It undertakes research, and its laboratories are recognised as centres of excellence. UKHSA bids for research funding and works with academia and industry to lead, promote, and deliver research and development that can contribute to future vaccine development. And in that regard, we can mention the 100-day mission. UKHSA provides the Secretariat for the United Kingdom's participation in the 100-day mission, which is a global initiative to better prepare the world for the next pandemic by driving the development of diagnostics, therapeutics, and vaccines so that they can be rapidly made available within the first 100 days of a future pandemic threat being identified. Further, the capacity to sequence and analyse the genome of a pathogen is a vital element of the modern response to any infectious disease. And UKHSA has a pathogen genomic strategy which seeks to establish a programme which, working with academia and the NHS, will increase our understanding of the characteristics of those pathogens that pose the greatest risk, so then offer opportunities to support the development of new therapeutics and vaccines. And of course, you will hear, my lady, of the involvement of UKHSA in its current oversight of the strategic partnership with Moderna. But if I move on to the second capability, and that is strengthening partnerships between government, industry, and academia. The work of the Vaccine Task Force benefited from the willingness of decision makers responding to an emergency to rapidly commit significant resource based on imperfect information and to take the risk that not every initiative would yield success. Such conditions are unlikely to pertain in peacetime, and therefore UKHSA seeks to develop and maintain systems which can be scaled up in the event of a future pandemic, as well as the key technical skills which will be necessary. UKHSA cannot do and does not do this in isolation. After all, its total budget is comparable to that of a district hospital. The VTF, however, demonstrated the benefit of closer working between government, industry, and academia. And UKHSA is committed to maintaining and embedding such working. To give your ladyship an example, there are now 14 health protection units, research units across England. Funded by NICE, these units are partnerships between UKHSA and a university. And they include a unit which is currently researching immunisation coverage in children and how to increase vaccine uptake in adults and reduce inequalities in the vaccine service. Science is always an international endeavour, and looking forward, the UK will want access to innovative products that can be developed swiftly, evaluated, licensed and delivered, and the opportunity to develop products itself. UKHSA's Vaccine Development and Evaluation Centre, or VDEC, seeks to work with industry, academia and the MHRA to identify the most promising vaccine candidates, support their development, and to provide preclinical and clinical trial testing. The third capability we would highlight today is that routine vaccination work in peacetime provides the bedrock from which to scale in a pandemic. The Covid-19 vaccination programme benefited from the infrastructure already in place for the delivery of routine immunisation programmes, and such programmes are delivered at local level, and that has proved highly effective. So, for example, the over 65 seasonal influenza programme has been recognised for achieving an exceptionally high level of coverage by international comparison. The benefit of working at local level, mainly through general practice, but as your ladyship has heard, through community pharmacies, is that you have a high level of patient registration, and also the information technology allows for the rapid identification of particular clinical risk groups. And what we mustn't forget is that sometimes being able to receive a vaccine in a familiar environment can support public confidence. Immunisation programmes in the United Kingdom are built on the principle of informed consent. Providing accurate information on the benefits and risks of any vaccine is critical, not only to inform choice, but to maintain confidence. And to support a robust consent process, UKHSA provides training and evidence-based resources for healthcare professionals, as well as public-facing resources. And these, of course, need to be available in a variety of format and languages. They need to be available for different age and risk groups. The information provided must be consistent across different formats and updated. And so we say that maintaining and improving the infrastructure for routine immunisation would be fundamental to mitigating potential harm from a future pandemic, because it provides a starting point for any scaling up of a vaccination programme. And that is particularly true at the early stage of any response to a pandemic, before, if they are needed, mass vaccination centres are established. My lady, the final capability we would speak about today is this, that surveillance of the real-world effectiveness of a programme and the presence of a robust system for safety monitoring are vital to both inform future policy and to sustain public and professional confidence in the programme. Of course, all pharmaceutical products are associated with side effects, and that includes vaccines. And where you have a mass vaccination campaign, assessing the benefits is at a population level. And that's the role of others such as JCVI, And it's that the role is to make an overall assessment for different population groups based on different levels of risk. Now, that will be informed, of course, by the MHRA's assessment of adverse effects and also any consideration of individual factors. Where taking on the work of Public Health England, but now carried out by UKHSA, where the agency comes in, is that it has established expertise in the surveillance, monitoring, and evaluation of routine vaccination programme. And the work in this area has often led the way for other countries. That expertise brings wider benefits. Firstly, it can inform the design and planning of a mass vaccination campaign. If you have surveillance data, that allows, for example, JCVI to better review its policy advice in real time. Second, Public Health England and now UKHSA has over many years surveyed the public's understanding of and attitudes towards vaccination. And that work is reinforced by activity across the public health system. At the start of the pandemic, public confidence in vaccination was strong. But retaining that confidence through local and national engagement, by studying and listening to concerns, and by the generation of high-quality evidence on risks and benefits is a prerequisite to any successful future rollout. Analysis of surveillance data informs the production of accurate information, vital at a time when inaccurate information about a vaccine's effectiveness or safety can be so easily spread. And it allows for consideration of the factors that influence confidence in particular vaccines. Vaccine hesitancy and vaccine confidence are complex issues, the course of which can be multifactorial and emerge over time. The third point to make is that UKHSA's surveillance and analysis functions can support decisions as to which vaccine should be deployed and to what schedule. It contributes to the overall health system's work in developing more tailored outreach services and in understanding the reasons why specific population groups may not be receiving immunisation. And that, of course, contributes importantly to tackling health inequality. Lady, those are brief submissions on behalf of UKHSA. You have submissions in written form as well, but can I conclude in this way that on behalf of UKHSA, I would like to repeat the agency's commitment to continuing to assist the inquiry with its work, and particularly in this module. Thank you.
Thank you very much indeed, Mr. Rudd. Mr. Hill.
My Lady, I appear for the Department for Science, Innovation and Technology, and in these submissions I will summarise briefly the role the Department and its witnesses played before turning to 4 themes relevant to the evidence you will hear in the coming weeks. The Department is a core participant as it's a successor to BEIS. The Government Office for Science sat within BEIS during the pandemic and sits within the Department now. As you know, the Government Office for Science was headed by the Government Chief Scientific Advisor for GCSA, Sir Patrick Vallance, as he was then, Lord Vallance, as he is now. That explains why we are here, but it does not explain what we did. The role of BEIS, the Government Office for Science, and the GCSA was limited in relation to the subject matter of Module 4, but nonetheless important. It is best explained by reference to the 3 witnesses whose evidence will be considered as part of this module. Lord Vallance gives evidence about his central role in the ideation, inception and establishment of a vaccine task force, the VTF. I will return to that shortly. Following the establishment of the VTF, his role on matters relating to the day-to-day work on vaccines was, by design, limited. Lord Vallance also coordinated and encouraged the work of scientists, government and funders in the early weeks of the pandemic, which is of relevance to both vaccines and therapeutics. He is not being called to give oral evidence, but has provided a detailed witness statement, which we suggest is essential reading to anybody who wishes to understand how the VTF came into being and the early impetus that drove the development of vaccines and therapeutics. Alexandra Jones was the Director of Science, Research and Innovation at BEIS. She is being called and will speak to her personal role in the establishment of a VTF, as well as the wider involvement of BEIS in matters relating to vaccines, therapeutics, and the National Core Studies Programme. Lord Sharma was, as Sir Alok Sharma, Secretary of State at BEIS between February 2020 and January 2021. He too is being called and will give evidence about his role in supporting the work of the VTF, about international collaboration on vaccines, and about the department's work on therapeutics. Two functions were at the heart of what BEIS, the Government Office for Science, and the GCSA did in respect of vaccines and therapeutics. The first was to help identify, encourage, coordinate and direct the extraordinary talents of the UK science and engineering base in academia and in industry. The second was to assist the government in making best use of that science and engineering base. These are, you may feel, matters of considerable importance, the more so given the speed with which that work was initiated. On the 27th of January 2020, before the first documented case of COVID in the UK, the first of a series of meetings of science funders was convened by Lord Vallance. At his request, and that of the Chief Medical Officer, a £30 million fighting fund was quickly established by the Treasury. This was used to invest in both the Jenner Institute's work on what became the Oxford-AstraZeneca vaccine and the COG UK Sequencing Consortium, which, by May 2020, was responsible for half the world's COVID-19 genome sequencing. Concurrently, work was ongoing on mapping the global R&D landscape on vaccines and therapeutics. These were efforts to identify and utilise both public and private sector, and we respectfully agree with CTI that the role of industry in this story must be emphasised. Those efforts took place outside of a public gaze and may have been underappreciated as a result, but they were the foundations of the success that followed. Having provided much of the early impetus and coordination, the department's official role in vaccines and therapeutics was thereafter limited. Other bodies and departments were more directly involved in policy and operational matters of concern in Module 4, and you will hear from those. My lady, we know that you're not assisted by us repeating what is in our written opening, and instead we use this time to highlight four themes. First, the establishment of a vaccine task force and its subsequent success resulted from a willingness to step outside the norm. As you will hear, the VTF was the idea of Lord Vallance, who identified the need for a dedicated expert and operational group with a single point of accountability to work on the vaccine response. The VTF drew upon private and public sectors and remained under ministerial oversight throughout. It was novel and it was innovative, but it was not a leap in the dark. The VTF drew on ideas set out in a paper co-authored by Lord Vallance in 2019, which itself formed part of a science capability review about which you've previously heard evidence. It was a combination of forethought and flexibility. Our second theme is that the VTF succeeded because it was prepared to fail. Scientific innovation is inherently uncertain. Any project will carry risk. This is particularly so for vaccine development. As CTI said yesterday, a regularly cited figure is a 10% prospect of success measured in a period of years. It was an extraordinary achievement to develop an effective vaccine within a year, thereby abating a pandemic mid-course. That achievement should not be diminished by familiarity with the ultimate outcome. To make this happen, the VTF and the government that backed it had to accept that there was a very real possibility that it would not succeed. As Lord Vallance says in his statements, and I quote, "It is not possible to have innovation without accepting the risk of failure." The risk was, however, carefully mitigated. The VTF deliberately adopted a portfolio approach to vaccine development to maximise the prospects of achieving its goal. The lesson to be drawn for government is of how to develop informed innovation and risk management in the future. There is also, we suggest, a wider lesson for society about how it encourages an environment where such innovation has the greatest prospect of success. To quote Lord Vallance again, had the VTF not achieved its central purpose, it would have been, quotes, lambasted as a huge waste of public money. The fear of censure when innovation fails is a deterrent to taking innovation risks in the civil service, end quote. The question of how innovation risk is treated in value for money calculations by the Treasury, the National Audit Office, the Public Accounts Committee, and more widely by parliamentarians, the media, and even lawyers at public inquiries, is both under-considered and important. In any future pandemic, there will be a need for innovation, and that will inevitably require an acceptance of risk and uncertainty of outcome. Our third theme is that the development of vaccines and therapeutics revealed national strengths and national weaknesses. Foremost among the strengths were the UK's science base, which includes the links between those scientists and their international colleagues, and the tradition of evidence-based medicine within the NHS, of which the recovery trial was the exemplar. The weaknesses included the limited domestic capacity for scaling up vaccine development and production. The focus on the response to Covid-19 also meant decisions had to be made on prioritisation, for example, by suspending some non-Covid clinical trials and focusing on phase 3 trials ahead of phase 2. The fourth and final theme concerns lessons for the future. Considerable work has been undertaken in this field, informed by expertise and experience. It cannot be properly summarised here, but it can be found in the statements of Ms Jones, Lord Vallance and Lord Sharma, and of course in the published work of the 100 Days mission that was started during the UK's 2021 G7 presidency. CTI referred to the 100 Days mission yesterday, and Mr Rawat has done so just before me. The three key lessons from that mission are, first, to invest in and restock the armamentarium during peacetime. Second, to embed best practice in business as usual activity, for example, in the day-to-day work of the NHS and, as Mr Rawat has said, in the ongoing vaccination programmes. Third, to agree the rules of the road in advance. At paragraph 149 of his statement, Lord Vallance also provides 7 additional reflections that he has drawn from his evidence to this inquiry. We invite all of those concerned to read this body of evidence carefully. My lady, in conclusion, the UK's efforts in vaccines and therapeutics saved millions of lives and livelihoods worldwide. These are remarkable collective achievements. This inquiry will hear evidence from some of those involved, but many thousands of others are also owed recognition and thanks. The scientists and the technicians at the lab benches, the administrators who enabled their research, the engineers and those who worked to manufacture the vaccines, those who administered the vaccines, as we heard from Ms Domingo earlier, and the members of the public who volunteered for the clinical trials and the vaccine delivery programmes. The success of the UK in vaccines and therapeutics was a consequence of the excellence, depth, and sense of public duty within its science and engineering base. That was in part a result of long-term funding for discovery research. In a future pandemic, the strength of the UK's response will correlate closely to the strength of that same body of expertise. That, we say, is a lesson for government and society alike. Thank you, my lady.
Thank you very much indeed, Mr Hill. And to complete the opening submissions, Ms Bikaregui, there you are. I hope I got the pronunciation right.
Bordar, my lady. My lady, you've received 10 witness statements from the Welsh Government for this module. Those statements and the written opening statement provide a substantial amount of detailed information. So this brief oral statement the Welsh Government will make 2 overarching points and then address some of the key issues from its perspective, but certainly not all of the key issues, my lady. The first overarching point is that the vaccine rollout in Wales was overall a success. The inquiry has a variety of written evidence before it, which show that Wales managed to vaccinate its population efficiently, equitably, and at pace. That overall success, my lady, does not mean, of course, that there are not lessons to be learned for the future. It's always possible to do better. And some important points, many important points have been made in these openings. At the end of this brief submission, I will set out some of the steps that the Welsh Government has taken to date to learn from the experience of the vaccine rollout. And it's anticipated, of course, that the report from this module of the inquiry will provide helpful learning to further improve the planning and the processes involved in vaccine and therapeutics. My lady, the second overarching point is something which echoes what my learned friend from the Scottish Government said, which is that from the perspective of the Welsh Government, 4 nations working in respect of vaccine development and supply and the development of supply and therapeutics was again overall a success. While some frustrations and disagreements are evident in the written evidence, and you'll no doubt wish to consider some of that, overwhelmingly the Welsh Government is of the view that 4 nations worked in a collaborative and a constructive way to make vaccines and therapeutics swiftly available. My lady, if I might address the context in which the Welsh Government is able to help the inquiry in respect of this module. As the inquiry is aware, healthcare is a devolved function in Wales and has been since 1999. However, in relation to vaccines and therapeutics, the position is somewhat more nuanced, with certain functions being reserved to the UK government. So the regulation of healthcare professionals, medicines, vaccines and their authorisation, and vaccine damage payments are all matters in respect of which legislative competence is reserved to the UK government. As your ladyship is aware, but those listening may not be, the vaccine damage payment scheme is a UK-administered scheme and is a matter reserved to the UK government. You've heard already, my lady, the MHRA is the regulator for medicines, medical devices and blood components for transfusion in the UK, which includes all relevant vaccines and therapeutics in respect of Covid-19. And pharmacovigilance is also the responsibility of medicine regulators and is undertaken by the MHRA on behalf of the whole of the UK. But separate and distinct to those reserved matters are those functions for which responsibility was devolved to the Welsh Government, but in the specific context of the Covid-19 vaccine procurement, a decision was taken to agree that the UK Government would exercise those powers on behalf of the Welsh Government. This was led by the UK Government's Vaccine Task Force, as you've just been hearing about, on behalf of all 4 nations. In agreeing this, the Welsh Government chose to allow its consequential share of vaccine funding to remain with the UK Treasury, with a Barnett share, which you've heard about, of the vaccine supplies guaranteed to Wales. And, my lady, I'd like to address you very briefly on the issue of vaccine allocation a little bit later in this submission. The operational delivery, my lady, of the vaccination programme in Wales fell to the 7 local health boards. But, and I should emphasise this, the rollout was overseen and supervised by the Welsh Government, and the detail of that oversight, my lady, is in our written evidence. My lady, the Welsh Government does invite you to consider the basis upon which vaccine supply is shared between the 4 nations. In the circumstance of the pandemic as it progressed, a decision as to allocation of supply had to be made very quickly and on a readily understandable basis. And really the only options available in the circumstances were for each, for sharing to occur with reference to the Barnett formula, which was already familiar to all of the governments as the basis on which funding decisions were made. But, my lady, in order to ensure that vaccines reach those in the greatest need first, the Welsh Government submits that a needs-based formula is needed to determine the allocation of vaccines in future. There was simply no realistic possibility for this to be calculated, agreed, and implemented in the time available during the pandemic. But now is the time, we would submit, to revisit this issue as part of our preparedness for the next pandemic. As you'll have seen set out in the Welsh Government's written evidence, the use of the Barnett formula created the potential for a vaccine supply shortfall in Wales during the early stages of the vaccine delivery. That was because Wales had a disproportionately larger share of older people in its population who, as you know, my lady, were a major part of the initial priority groups. So the ingenuity, my lady, of those in the Welsh healthcare system meant that a shortfall in supply was avoided. There were several elements to this, but a key factor was the steps taken to avoid vaccine waste, with vaccinators in Wales identifying early on how to extract 6 doses per vial from the Pfizer vaccine instead of 5 doses, which was originally intended, and achieving this, my lady, quickly at scale. So this ingenuity and some other steps taken in Wales should not detract from the need to consider the fairness and the appropriateness of the Barnett formula in deciding population share of UK vaccine stock. And that's because, my lady, as I've said, it doesn't take account of the relative size of the population at risk in terms of what vaccination is needed. And it's submitted that vaccines could and should in future, where possible, be allocated according to need. Your ladyship will be considering the important issue of equity in the rollout of the vaccine. The question of health, socioeconomic and other inequalities has been a focus of successive Welsh governments since the outset of devolution in 1999. And my lady, that prior focus meant that the Welsh government had an early understanding that Covid-19 would produce disproportionately adverse effects on those already disadvantaged or from suffering some other pre-existing health condition. So, my lady, the Welsh Vaccine Equity Committee was established in March 2021, with its impact and influence increasing as the pandemic evolved. It involved representatives from the underserved groups themselves, from third sector organisations, as well as experts from Public Health Wales and the NHS in Wales. And it sought to understand the barriers to uptake of COVID-19 vaccinations in marginalised groups and to work to remove those barriers. The Welsh Government published a vaccine equity strategy in June 2021 to ensure all people in Wales who were eligible for Covid-19 vaccination had fair access and a fair opportunity to receive their vaccination, again by addressing barriers to uptake, which disproportionately affected underserved population groups. And very briefly, my lady, and this doesn't go anywhere near to answering much of what was said yesterday, but the strategy did refer to asylum seekers and it did refer to those from traveller communities as requiring a particular focus to ensure that they could access the vaccine. The Welsh Government implemented various measures to ensure the accessibility of the vaccine to and to encourage take-up amongst those communities. Just to give a few examples, measures included the appointment of outreach and engagement workers within each local health board to support with engagement and advocacy relating to the vaccine programme, and the use of community champions or trusted voices comprising of faith leaders, community leaders, sports and cultural figures, health professionals, academics and peers of eligible and vaccine hesitant groups in a range of communities. In addition to the Vaccine Equity Committee, DNA, which did not attend, a DNA group was also set up to specifically target the issue of hard-to-reach groups. The Welsh Government also held specific events intended to target those harder-to-reach communities for those who were vaccine hesitant, including an online vaccination roundtable to permit representatives from multicultural faith community and business organisations from across Wales to ask questions and to hear from a panel of experts. My lady, very briefly, vaccine misinformation was a concern and was identified as a key theme in the All Wales Equity Action Plan, with significant efforts made to promote accurate information to the public in Wales, which included the establishment of a community engagement group to work with community leaders and organisations representing particular communities. My lady, the Welsh Government enjoyed relatively high levels of trust from the Welsh public, which meant the public were generally responsive to its public messaging on vaccine-related matters, and that ensured that the Welsh Government measures were generally well supported. But misinformation is a difficult issue and one which is increasingly hard to target as people source their information in increasingly fragmented ways, and the Welsh Government is keen to hear any suggestions which the inquiry has on this complex topic. Lady, briefly on lessons learned, which I mentioned at the beginning, the Welsh Government has sought to learn lessons from the rollout of vaccinations during the pandemic to support delivery of all of its ongoing vaccination programmes. It carried out an assessment of vaccination priorities and expectations for the future, and on the 25th of October 2022, it published the National Immunisation Framework. The framework is intended to pave the way for a transformation of the vaccination programme in Wales, enabling exemplar delivery of vaccination and immunisation programmes with uptake and with equity at its core. It aims to make it easier for people to know that vaccinations they're eligible for, how to receive them, and it uses digital vaccination records. Local health boards are also required to have a vaccine equity strategy and a programme of work applying the framework's principles. And again, my lady, to ensure that vaccine equity is considered at every stage and to protect the no one left behind principle, which was part of the Welsh Government's vaccine strategy published during the pandemic, the Welsh Vaccine Equity Committee is part of the new governance arrangements under this framework, with an expanded remit to deal with all vaccination programmes. Lastly, my lady, whilst most of this submission deals with the undoubtedly positive effects of the vaccine rollout at a population level, the Welsh Government, of course, acknowledges that some individuals were harmed by the vaccine. And again, for some of those people, those harms are ongoing. And we say it's important, as Mr. Keith Casey set out, to acknowledge that and to listen to those affected in that way. The Welsh Government also wishes to acknowledge the very hard work of GPs and many others within the Welsh population. My lady, you saw an example of a Welsh GP in the impact video that was shown. Many of those people who sought to reassure and to reach communities who were worried about having the vaccine. Again, with respect, we agree with Council to the Inquiry and other core participants that it's important that this work on vaccine equity and reaching hard-to-reach groups is ongoing and survives the pandemic. And as I mentioned also at the beginning, my lady, the Welsh Government acknowledges that there are further lessons to be learned, not only from what went well, but also what we could have done better. And we welcome the inquiry's analysis of those lessons to be learned and improvements that can be made to ensure the success not only of future vaccine programmes, but also of the delivery of therapeutics. Diolch, my lady.
Thank you very much indeed. That, I think, completes the submissions. Some extremely helpful and interesting submissions have been made, and I shall undertake to consider them all very carefully with Council to the Inquiry, and also to ensure that I read all the written statements again very carefully. Mr. Keith, I think we now move to the first witness.
My lady, yes.
I think we've undertaken to hear her before the break.
Indeed. So may we have our first witness, please, Jean Rossiter. And if she could be sworn.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
My lady, we're not going to seek in relation to any witness your permission specifically each time for statements to be published.
No, by
Lest we
default.
raise something by default. Thank you.
Mr. Rossiter, thank you very much for coming to help us. I hope it's not too difficult for you, and we'll obviously take any care that we can to make sure that it's a relatively pain-free experience.
Thank you.
Mrs. Rossiter, thank you very much for attending today and assisting the inquiry. You very kindly provided two statements, 8406 and 4666, dated both, I think, dated December 23 and December 24. I'm sure you've read them both in advance of attending today. You are a member of the group Covid-19 Bereaved Families for Justice UK, and I had the privilege of hearing in Module 1 from Matt Fowler, from Joanna Goodman in Module 2, and Mr. Sullivan in Module 3, although, as we know, he sadly passed away. So I'm not going to spend any time asking you about the nature of your group, because we know a great deal about it already. Other than this, it came into being, did it not, around about the end of April 2020, after Miss Goodman lost her father and Mr. Fowler lost his father, and they liaised online, came together and realised that there was a very significant need for such a group to be founded. Is that right?
That's correct.
And I think it has almost 7,000 members now from across the United Kingdom. And of course, the terrible link between you all is that you all lost loved ones to COVID or suffered some form of harm in the course of the vaccination or therapeutic programmes. Mrs. Rossiter, may I ask you please about your son Peter, whom I know you lost on the 11th of August 2021 when he passed away having suffered from COVID. He was a very remarkable musician, I gather.
Yes, he was. Peter was... sorry.
It's quite all right.
You're bound to get distressed. We do understand. So just take time, drink some water. I sometimes find that just having a break by drinking some water helps the concentration. But please don't apologise.
Yeah.
There are tissues there if you need them.
But was he, Mrs. Rossiter, in fact, Young Musician of the Year in high school?
Yeah, he was a very talented, classically trained pianist.
And he studied at the Royal Northern College of Music, and I
Yeah.
think in the Franz Liszt Academy of Music in Budapest.
Yeah.
And he was working, was he not, at a school where, at the time of his death, he was head of a particularly important part of the music structure there.
Yeah, Peter he originally worked on supply as a teacher once he qualified, and he had some difficulty initially getting a job, but he secured this job mainly as a maternity leave job. He providing cover for that teacher, who then decided not to go back to school. So he started as a teacher, and he very quickly progressed to become head of that music in that school. At the time when Peter first started, music, although it was being presented in the school, it wasn't really taken up that much by the kids. He actually managed to bring that subject right up, and he really made it into a very popular subject. He even actually managed to get kids to take part in the school concerts, which they wouldn't do before. He arranged bands, he got them into groups, and he even managed to get some of the staff to actually form a group as well, and take part in the concerts with the kids. So it became a very popular subject in the school.
And he was the subject leader, he was the head of the music department.
Yeah.
We understand that he continued to work there throughout the pandemic.
He did, yes.
And the school had obviously remained open for the children of key workers and looked after, I think, other children who had SENs. He had to wait for a while until he was called up for his first dose. He received a vaccine on the 14th of May 2021, but I think that there were problems getting a second dose. The process by which he came to be invited for a second dose wasn't very straightforward, was it?
No, it wasn't. He only got his first vaccine in May. And I have to add at this point, when Peter actually got his first vaccine, this was at a point when everything in the country was starting to open up, and shops and restaurants and the schools had gone back, were all open. People were allowed to gather. The European Cup final was on, and people were gathering to watch that. And Peter only then was getting his first vaccine. He'd had to wait until May, despite the fact that he, as a teacher, was a key worker. And, he was looking after children of other key workers. And those key workers were actually in contact with COVID cases, or some of them were. The children were seen at the time to be carriers of the virus. And to this day, I can't understand why teachers were not given priority for that virus, for the vaccine.
And notwithstanding that he did receive a second dose, he caught COVID afterwards.
He only received his second dose 8 weeks after the first dose. That was in the July. And I was really very concerned about this, because I thought that the manufacturers of the Pfizer vaccine had said for ultimate for protection, you should have the vaccine within 3 weeks. And yet Peter waited 8 because the science, so I believe, said that you were okay up to 12 weeks. Now, Peter had his second vaccine in 8 weeks, and yes, even his first vaccine hadn't protected him.
And one of the important issues, of course, we're looking at in the course of this module, Mrs. Rossiter, is the dosage interval. So we'll be hearing plenty of evidence on that topic. After he received his second dose, he nevertheless got COVID, and very sadly fell very seriously ill very quickly.
He did.
He was taken to hospital. He was placed in an ICU, and I'm very sorry to say that despite being intubated and looked after there, he passed away on the 11th of August. So you've obviously got some very serious concerns about the key worker issue, whether or not he should have been offered a vaccination earlier, and the dosage interval as well.
I'd also query, if I could, about
Please.
the quality of the vaccine and, you know, whether or not was there something wrong with that vaccine that it didn't protect Peter? I don't know. I've no way of checking on that, and nobody was able to tell me. I even contacted Pfizer themselves about the vaccine, and they actually told me that when Peter had his second vaccine, because he actually tested positive so soon afterwards, he wasn't fully protected. It just didn't make sense to me.
Vaccines, of course, we will hear don't provide 100% protection, but we'll be calling evidence about the degree of efficacy and effectiveness and what sort of protection they provide. So that's another important issue that we will look at. Mrs. Rossiter, given the large membership of Covid-19 Bereaved Families for Justice group, your members have obviously raised a wide variety of issues, and have you taken the care to identify some of those issues and concerns in your witness statement? I'm just going to run briefly through and identify some of the major points which are raised in your statement, and if you just agree, if you'd be so kind, as to whether or not they are indeed matters which have been raised through you by your members. Going beyond, obviously, the tragedy of individual cases where people died from COVID, we can't do anything about investigating individual cases. But the issues which are raised in general terms by your members are delays in receiving vaccines, so a question about the delivery of vaccines and how quickly they were made available, concerns about poorly communicated public health guidance. Quite a few members have raised concerns about this issue of the dosage interval.
Absolutely.
And also between the gap between the second and third doses, between the second and the booster doses. In your legal team's opening submissions, questions have been raised about specific prioritisation. For example, there's one particular boy who had complex needs but didn't appear to have received early vaccination. There is the general issue of availability of and access to antivirals and therapeutics. That's been raised by quite a few of our members, hasn't it?
Yes, it has.
You've mentioned the issue of whether or not key workers should have been prioritised for early access to vaccination beyond working in the health and care sectors. Do quite a few of your members ask why particular sectors of the population, such as transport workers and teachers, didn't receive priority vaccination?
Yes, indeed.
And also, very credibly on the part of these members, quite a few of your members have asked questions about whether other people in the United Kingdom, but particularly members of the ethnic minorities, properly received access to vaccination, to vaccines, and also whether or not the system equitably allowed for them to receive vaccines when they were due to receive them.
Yes.
That seems to have been a point of particular concern for your members, that everybody had a fair crack of the whip.
Yes.
Right. Mrs. Roster, that's extremely helpful. Thank you very much. That allows us to understand more clearly the main areas of concern that your members have had.
Ms. Roster, I too am the mother of 2 sons and of similar age to Peter, so I can only imagine the pain and the grief that you're going through. So thank you so much for coming along to help us. I know you've already done a lot to ensure that his memory doesn't die, and I hope that your remarks today, your helpful evidence, will help keep him alive as well. And I think, as well as the important points that Mr. Keith has just taken you through, I think one of the most important points from my point of view is that so many people said COVID-19 only affects the older people.
Exactly.
You had a fit and healthy young son, under 40. And so it helps remind people that we're not just about protecting people who some may think have had a good innings. We're about protecting the whole population.
It is indeed, yeah. Yeah, Peter was, he always kept himself fit. And he followed the rules. We all did. And it just seems to us as parents is that we did everything right, and yet Peter lost his life still, as did so many of similar families who were in our group. And I believe all of our families really deserve to be heard and for those cases to be taken into account. Thank you very much for letting me come.
Well, thank you very much for all the help you've given, having the courage to come along and help me. And I know that when I break, your legal team will ensure that you have the support that you will need, but also the inquiry, as your legal team know, provides support if you need it as well. So thank you very much indeed.
Thank you.
I shall break now and return at, shall I say 22, so that the team can have a chance to talk and then perhaps have a break themselves. 22. Yes.
My lady, the inquiry calls Melanie Newdick, please.
If I can ask you to repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth
and
nothing but the truth.
and nothing but the truth.
Thanks.
Studio, I hope we haven't kept you waiting for too long.
No, it's fine.
And we totally understand this is going to be really difficult for you, and we're very grateful to you for coming along.
No worries. It's 600 miles to come down, so...
Oh, goodness, I didn't realise you'd come quite that far.
Yes, yeah.
Please could you give the inquiry your full name?
Yep, my name's Melanie Newdick.
Thank you very much for attending all that way to assist the inquiry today. A few preliminary matters. I'm going to ask you to keep your voice up. Please don't speak too quickly, and ask me to repeat anything if it's not clear.
Okay, yep.
You have kindly provided a witness statement to the inquiry on behalf of Scottish Covid Bereaved, or SCB, and that is INQ 472173. Are the contents of that statement true to the best of your knowledge and belief?
Yes.
The inquiry is, of course, familiar with Scottish Covid Bereaved and is grateful for the evidence it has provided in earlier modules of the inquiry. I'll deal very briefly with the background of the organisation. It started out as part of the group Covid Bereaved Families for Justice UK, which was formed on Facebook in June 2020.
Yes.
Then in September 2022, SCB became a completely separate group.
Yes, it did, yeah.
You note the diversity of your membership, which includes healthcare and other frontline and key workers.
Yes.
And you note that some of those are suffering from post-traumatic stress disorder and other impacts of the trauma that they experienced during the pandemic.
Yes.
You also have members who are either from an ethnic minority group or have a loved one who died who was from an ethnic minority group.
We do, yes.
And in that regard, you highlight the Scottish Government vaccine data, which shows that the highest vaccine rates were for white people with lower uptake among ethnic minorities.
Yes.
You also have members suffering from long COVID.
Yes.
And your aims, very briefly, are that you're a group of bereaved individuals united in a common goal.
We are.
And by sharing your experiences, you want to assist this inquiry and the Scottish inquiry in establishing what happened and making recommendations for the future.
Absolutely.
Now, your statement deals with a number of issues of concern to SCB, and I want to start, please, with the pace of delivery, vaccine delivery in Scotland, including vaccination of vulnerable hospital inpatients and care home residents. This is a topic that is of particular concern to SCB. Could you tell us a bit about the concerns you have?
Yes, if we take ourselves back to when we very first had vaccines at the end of 2020, there was an initial fast pace of delivery, but that slowed, so it was not delivered across the same pace across the whole of Scotland. So the part of Scotland where I live, which is a very remote part of Scotland, the delivery slowed because Christmas came. So some people didn't get the vaccine as early as they could, which could have had impacts for them as well. And we also had the situation where people missed their opportunity to get vaccinations because they were in hospital, which seems incredible, really, when you think about it.
Another issue you raise is the question of whether Scotland lagged behind England in terms of delivery. Is that something else that you're?
Yes, we would really appreciate some insight into that from the inquiry. And then, when you look at particularly the difference between the different parts of Scotland. Scotland's pretty huge. It's a third of all the land in the UK. And the bit I'm in is a very particularly remote part of Scotland as well. So there's some real differences in the speed of delivery delivery within Scotland itself.
You also highlight the fact that different health boards in Scotland took different approaches to vaccination delivery.
Yes.
What are your concerns about that?
Well, I'm not sure whether the inquiry is aware that now in Scotland we have a completely different process for vaccinations than you have here in England. So you are able to go to your GPs to get vaccinations. We can't do that anymore in Scotland. From April 2023, no GPs in Scotland, or very few, have been able to give any sorts of vaccinations, not COVID, not flu, not all the childhood vaccinations. We have to go through a completely different process. We have to go to clinics arranged by the health board. So our concerns are now whether if we put ourselves back to when we had the COVID pandemic, if we had another pandemic tomorrow, would our system be able to deliver vaccines at the pace that we did previously? And at the minute, the data seems to say that it can't. We're seeing a lot of differences in vaccine uptake. So to give you a very quick example, we're having a huge flu outbreak at the minute, as I'm sure you know. The vaccine uptake in the Highlands, when the GP is now half the rate compared with the new system compared to what it was when GPs provided that service. So that's huge implications for everything, but also for another pandemic.
You've mentioned the GP model. Was that particularly important in Scotland for reaching rural communities?
It's really important. It's really important for everybody. I mean, any vaccine system should be designed to make it as easy as possible for as many people as possible to get a vaccine. So now we have an extra step, which doesn't just make it difficult for everybody to get a vaccine, it makes it even more difficult for those that we already talked about, anybody in an ethnic group, anybody from a deprived area, anybody who has any concerns about vaccines. That's now an additional step and an additional barrier that we have in our system that you don't have in England.
So can I just go back? So what is the system? So I recently had the RSV infection jab.
Yep.
So just go down to my GP and it's done.
Yeah.
How would you do that in Scotland?
Okay, so knowing that I was going to come down here, and you've got a lot of flu in London, I rang the vaccination helpline, and I could have gone to a clinic today, 20 miles away from home, between 1 and 3 p.m. I could go to a clinic tomorrow, which is 220 miles away from my home, which is the next one available. We have to ring the health board, or we have to go online and we have to find a clinic to go for that vaccination. We can't go to the GP for any vaccination, not a tetanus, not a childhood vaccination, not a flu, not a COVID, nothing.
And do they have hours that cater for people who are working during the normal working day, but isn't normal working day for everybody?
No. All the hours, I had to look at the whole schedule for January. Most of the hours are something like 10 to 12 or 1 to 3, 2 to 4. There's no evenings, there's no weekend clinics either. So it makes it very difficult.
You don't imagine?
Yes. Yeah.
We've touched upon barriers for vaccination for people, and one of the issues raised in your statement is the barriers faced by elderly or those vulnerable people in shielding categories. What are SCB's concerns in relation to that?
Well, we raise concerns about having to go to take vulnerable people to vaccination clinics. That is now the system. You have to go to either a specific day where people are coming in, or you have to go to a drop-in clinic to get your vaccinations. So our concerns are, is this new system, is it making it easier, or is it making it more difficult for those people to access vaccines?
I think those are the major areas of concern that we've touched upon. I just want to go through at quite a high level some of the other issues raised in your witness statement. One of these is communication about vaccine development and SCB's concern that the development of the COVID-19 vaccines wasn't communicated clearly enough to the public so as to alleviate any concerns about it. Is that right?
Yeah, and I think in the opening statement yesterday, Mr. Keith set out what the process was, and instead of it being a linear process with the steps following on from each other, they ran concurrently. But I'm not sure people knew that. And maybe if that had been communicated, it might have helped. And then that would have stopped people thinking that the process had been shortened and steps had been removed.
Another issue you raise is the cancellation of the Valneva contract. This was the UK government's decision to cancel the contract with the vaccine manufacturer Valneva. The company was due to manufacture some of those vaccines at a plant in Scotland.
Yes.
And you would like to know, and your members would like to know, if the cancellation had an impact on the overall vaccine programme in the UK or in Scotland in particular.
We absolutely would, especially considering that Valneva went on to get full European approval, and because the type of vaccine would have been really it's especially suitable for people with health conditions that couldn't have other vaccines.
That's right. It's a different modality to mRNA vaccines, for example. Another issue you raise is the vaccination of key workers, and you ask why certain key workers were prioritised over others.
Yes, and I think we have questions about, again, whether how those decisions were made. Was it the role they were doing, the type of job? How did those decisions come about? So quick example. When we had the initial vaccines for care home residents, care home workers couldn't get the vaccine at the same time. So in our local care homes, that's how COVID went into the care homes, from a community outbreak through the staff, and then 47 people died in my local town, just in care homes from that outbreak.
In your statement, you set out a number of lessons that you believe can be learned about vaccination and therapeutics in Scotland, and recommendations for the future. One of the main issues of concern for SCB was the distribution of the vaccine to those in vulnerable categories. Is that right?
Yes, we had some concerns about that, how that happened for COVID-19. We have some concerns about how that might happen under this new system, and would the same people have the same problems, or would it be more accessible this time?
You also highlight the fact that in future it may be helpful to consider allowing individual health boards to implement their own system for vaccine distribution in the future, suited to their particular population. Is that something you'd like to see?
Yeah, exactly. So the Highlands, where I live, it's geographically the same size as Belgium. It's got 2.5% of the population, but we have to use the same centralised system because that's what the Scottish Government has told all the health boards in Scotland they have to do. It doesn't work for a remote rural community. Who is going to drive 220 miles to get a vaccine? I'm very keen on vaccines, but even I'm not going to do that. So we need a system that's actually going to work for the population that it serves, and not a central one-size-fits-all policy.
You would also like to see better communication in the future with relatives in situations where therapeutics are being offered, and you make the point that those who are unwell and vulnerable may not be in a position to make decisions alone.
Yes, I think we would like to see much better communication around those. So again, what lessons going forward? Yeah.
And you also raise the issue of access to accurate information, and we've touched upon this already in discussing the development of the vaccines, but you are concerned about people being able to make informed decisions about vaccines, and therefore you would like to see some stricter controls on social media and indeed the mainstream media when it comes to misinformation.
Yes, I'm sure you're aware that one of the Facebook has just decided it's going to get rid of all its moderation and go for community moderation. That's potentially got a huge impact. I think an important thing to remember to think about for vaccine hesitancy is that the hesitancy is not usually about vaccine. It's usually comes from trauma and the impact that has on trusting anyone in authority, whether that be a health board, police officers, solicitors, maybe, I don't know. So that's where it comes from. So it's about having, it's thinking about it in a trauma-informed way, which I know the inquiry does. Our system in Scotland currently has put an extra barrier for those people. They can no longer have a chat with their GP, and they can no longer, when they're in for something else, the GP can no longer say to them and take that opportune moment to say, okay, let's get your vaccinations done. Well, I've got some questions about it. Okay, let's deal with them now. It doesn't work like that anymore. So we've made it even harder for the people. Well, and just quickly, that system, when it was designed, the Scottish Government, they got in members of the public to talk to them about redesigning the new system. They deliberately excluded anybody that was vaccine hesitant, saying that they felt they had nothing to add to the process. Really, if we'd have built the process, this new process, around those people, it would have worked for everybody else as well, and they would have had more access to vaccines, which are, after all, the most successful public health intervention we have.
Ms Newdick, we have covered a huge amount of ground. Thank you very much for that evidence. My Lady, that concludes the evidence of this witness, unless you have any questions.
Thank you, Ms Mansell. We haven't dealt with your own bereavement, Ms Newdick, but I know that you've told the Scottish inquiry about the death of your mother, and I appreciate it must have been, I've read it, it must have been extremely difficult for you, but at least you got her home.
Yes, we did. Thank you. Thanks.
And thank you so much for all the very constructive and helpful comments that you've made. You're a very good advocate for the cause. Thank you very much.
No problem. Thank you.
And safe journey back.
Yes, I'll be flying back tonight. Thank you.
Do you follow us remotely?
Yes, absolutely. Thank you. Thank you.
And I understand that, Ms Mitchell, if it's okay with you, we'll carry on, but thank you. Mr Mansell.
My Lady, the next witness, please, is Fiona Clark.
I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth and nothing but the truth.
Hope we haven't kept you waiting, Ms Clark.
It's okay. Thank you.
Could you give the inquiry your full name, please?
Fiona Louise Clark.
Thank you very much for attending today to assist the inquiry. I'm going to ask you to keep your voice up, please.
Yes.
Speak into the microphone so that the stenographers can make a note of what you're saying. Ask me to repeat anything if it's not clear. You've provided a witness statement to the inquiry on behalf of Northern Ireland Covid-19 Bereaved Families for Justice, or NIC-BFFJ. That is INQ 474358. And are the contents of that statement true to the best of your knowledge and belief?
Yes, it is.
The inquiry is familiar with the group NIC-BFFJ, and it has benefited from the evidence it has given to the inquiry in earlier modules. The group started in December 2021 and is a branch of the UK-wide COVID Bereaved Families for Justice group. Is that right?
Yes, that's correct.
It was formed as both a support group and an action group. and seeks to challenge decision makers to highlight issues and safeguarding concerns, as well as address the detrimental impact that visiting restrictions were having upon patients and residents in hospitals and care homes and their families.
Yes,
Is that
that's correct,
Is that
yes.
right? You explain in your statement that the group represents and is made up of members who have lost loved ones to COVID-19 in a variety of circumstances, including in care homes, hospitals, and in the community.
Yes.
And the aims of the group include applying pressure to ensure that there is accountability for the past actions of the UK and Northern Ireland governments, and providing a collective voice for bereaved families and a supportive space for them to connect.
Yeah.
Now, I'd like to ask you at the outset, please, to speak a little about your mother, Margaret Lusty. Your mother sadly died in January 2021 at the age of 90.
Yes.
She had been a shop owner and proprietor earlier in her life.
Yes.
You describe her as a country woman from Cookstown and say nothing would get her down.
That's right.
And despite her age and health difficulties with kidney disease, she was still independent and still driving. Is that right?
Yes, that's right.
Your mother was in the phase 1 priority group for vaccination. She received a first dose on the 7th of January 2021. That was around 5 weeks after the vaccine had first been approved.
Right.
And her experience of being vaccinated was a positive one.
Yes.
Could you speak a little bit about that?
Yes, the vaccination, we all wanted to be vaccinated to protect her. We didn't want to bring COVID into her. She was also looking forward to getting her jabs to protect herself. Now, whenever she was vaccinated, I was in hospital myself at that time with COVID. So I really wasn't aware the process, if you like, of her going through, but she was happy enough. I remember her telling me it was like a conveyor system, and things were done very safely, and she was quite relieved to get the first vaccine.
I think she went with your brother. Is that
Yes,
right?
my brother took her, yes.
To be vaccinated at a local health centre in Glengormley, and it is, as you've just alluded to, a rolling system. She went in one door
And out the other.
and out the other,
Yes.
which was something that was thought to be very good because she wasn't spending a lot of time with other people in that setting.
That's great. She said to me that it was she was just in and straight out again. So
Did she not do the... I remember you had to sit down for 15 minutes or something after. Did she not do that?
no,
Oh.
no, she was straight out. She said straight out the next door.
It may have been that was introduced slightly later in the process, but we can
It may
we
be,
can get to
because
the-
I wasn't
get to
in the
bottom
first
of that.
cohort.
Nevertheless, despite that positive experience with the vaccination itself, your mother tested positive for COVID-19 on the 12th of January 2021 and was admitted to hospital on the 16th of January.
Yes, that's correct.
You were at the same hospital, as you've explained, because you had COVID-19 at the time.
Yes.
You were allowed to see her in the hospital. You explain in your statement that it was a bit of a battle, but you got to see her.
Yes.
You sat with her all night and comforted her. And you managed to see her again the next day. But is it right that she died later that day on the 17th of January 2021?
Yes, she died about 2:45 that afternoon.
You have set out in your statement in very moving terms the sad and distressing experience that your mother had while she was in hospital. One of the issues you raise is whether your mother was provided access to therapeutic treatment while she was in hospital.
Yes.
Something that's of concern to you.
Yes.
Your mother's story raises a broader issue about vaccines, does it not? And that is about the pace of vaccine development and approval, and whether things could have been done quicker.
Most certainly, yes.
Is that something that is of concern more widely to NIC BFFJ members?
Well, it's such a vast group. You know, we have different opinions on this. My opinion at that time, because I was living with my mother, was to protect her. And my mother's opinion was she would take the vaccine to stop her from getting COVID, or the symptoms from being as severe as what we believed them to be. There's other people within the group who don't believe in the vaccines, who believe that the vaccines have maybe caused illnesses. That certainly is not mine.
One thing you raise in your statement is that you would have quite liked the option for your mother to have received a vaccine before it had been through the authorisation process. And is
yes,
that
I would have.
Is that something you think she would have been interested in herself?
I know she would have been, yes.
I'm going to move through some of the other issues that you raise in your witness statement that are relevant to this module of the inquiry now. But thank you for sharing that story about your mother. One of the issues of concern to your group is relatives contracting COVID-19 from staff who were carrying out the vaccination programme.
Yes.
Could you tell us a little bit about the concerns that you have about that?
Well, people within care homes, for instance, you know, their family members who were vaccinated, they never got to see their loved ones or got to be with their loved ones. Maybe people within the care homes that were working there haven't been vaccinated. And it was so hard to get my head around that. My sister at that time, she was working in a care home. And it was also haphazard at that stage. Do you know, there was no uniformity. Some care homes, you were allowed to be with your loved ones, some you weren't.
Another issue you raise in your statement is access to vaccine clinics and vaccination centres for housebound and elderly patients.
That's right.
That's something that is of concern to your members?
Yes, it is. There's parts of Northern Ireland that are quite rural, and there are people, if you like, they're immobile. They should have had like a doctor on call to go out and administer the medication, administer the vaccines. It would have been so much more helpful.
You're concerned there were missed opportunities?
Absolutely.
For vaccination?
And again, it was just down to bureaucratic rules, really.
You've explained that within the group there are different views on different aspects of vaccination.
Yeah.
The issue of vaccination as a condition of deployment is one that perhaps splits opinion within your group. Could you give us an idea of what the views are?
Yes, certainly. There's people that don't believe in the vaccine. They believe that the vaccine could possibly cause more harm than good. But my intentions at that time, I can only really say my intentions. My intentions at that time was to protect my mother. I was going to work, I was coming home, and I needed to protect her, so I would have taken anything, regardless. You know, if I had no concerns if it was going to do me harm, it was to protect her.
You question why in June 2021, when the government in England indicated that vaccines would become compulsory for care home staff, the government in Northern Ireland did not take the same approach. Is that something that is of concern to you?
Absolutely. It was just, as I said before, it was so haphazard. Nobody knew what the other one was doing.
Another issue you raise is in relation to public messaging and the clarity and adequacy of public messaging on vaccines and vaccine delivery. And you say that some of your members would like to know whether the Northern Ireland government's messaging about vaccine efficacy was in terms of absolute or relative risk. It's understanding how those figures were presented to the public. Is that what you want to understand?
Yes.
Vaccine safety is raised within your statement. You've explained you had no concerns about vaccine safety. Some of your members do have concerns, and you wonder whether there's any perceived lack of openness about the process for development contributed to vaccine hesitancy among some people in Northern Ireland. Is that
Yes,
right?
absolutely.
You also raised the issue of disparity in vaccine uptake, in particular as between health service staff and staff in care homes. Perhaps this goes back to the haphazard point you were making before. And you set out a series of recommendations that you would like the inquiry to consider. Is there anything in particular you want to say today about lessons learned or recommendations you'd like to see implemented in the future from your group's perspective?
I found that whenever I was in hospital, I can't remember in the time that I was there that I seen the doctor. It was all nurses. Certain hospitals would have been more willing, shall we say, to let people be with their loved ones than others. I found it very cruel. I found it very inhumane way to treat people. Again, I'm only talking about my own personal opinion.
Is it right that you stress, and NIC BFFJ stresses, that a partnership approach between patients and patients' families and healthcare providers is important in this context, so that there is communication and understanding of these issues?
Good communication is skill, yes.
You also explained that there should be proper engagement by healthcare professionals with patients and patients' families in order to explain and advise on the available therapeutic options, perhaps something you felt was missing in relation to your mother.
Yes.
You also stress the urgent need to develop and trial therapeutics for treating long COVID.
Yes, definitely, yes.
And is there anything else you would like to tell the inquiry today that's relevant to vaccines and therapeutics?
No, that's it.
Okay. Well, my lady, that concludes the witnesses.
Thank you, Mr. Mansell. Thank you very much, Ms. Clark, for coming on to help. It sounds as if your mother was a wonderful character.
She was, yes.
You must miss her enormously. And COVID's obviously hit your family really hard, and it's hit you particularly hard. You've been hospitalised with COVID, and you're still suffering from long COVID. So
Yes.
I can imagine how difficult it must have been for you just to travel here. So thank you for making the effort. You have come from Northern Ireland, have you?
Yes, I have, yes.
Yeah. Well, wishing you a very safe journey back, and thank you so much for your help.
Thank you, lady. Thank you.
Mr. Keith.
The next witness is Anna Miller, please.
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
Thank you for your advocacy. There's so much to give.
Could you commence, please, by giving the inquiry your full name?
Yes, it's Anna Catherine Miller.
Ms. Miller, thank you very much for attending today and for assisting the inquiry. Whilst you give evidence, could I just remind you to try to keep your voice up and speak as clearly as you can into the microphone so that it can be recorded by the stenographer as easily as possible.
Yeah.
You very kindly provided a witness statement dated the 4th of October 2024 on behalf of the group whom you represent today, the Migrant Primary Care Access Group. It's INQ 000474407. Was that a statement that was prepared jointly by senior employees of the 4 organisations within the group that you represent?
Yes, exactly.
Let's just have a look for a moment, if we may, at what those 4 organisations consist of. The first one comprises Doctors of the World UK. Is that part of Médecins du Monde?
Yes, it's part of the Médecins du Monde International Network.
And what, in essence, is that group concerned with?
So we're an international, it's the organisation that I work for, and we're an international organisation that provides medical care across the world. Sometimes it's in emergency settings, but also sometimes it's looking at unmet healthcare needs in countries that have fairly well-functioning healthcare systems and supporting people who aren't able to access those healthcare systems.
And are you head of policy and advocacy, in fact, at that organisation, Doctors of the World UK?
Yes, in the UK, yeah.
In terms of its functions in the United Kingdom, does it help support a number of individuals, enabling them to access NHS services better?
Yes, exactly. We see between 1,000 and 2,000 people a year, and it's always people who are struggling to access NHS services.
The second organisation is the Joint Council for Welfare of Immigrants. Is that a charitable organisation that advocates for migrant justice?
Yes.
And very roughly, how many clients or people on an annual basis does the Joint Council support? We don't need the precise figure, Ms. Miller, but roughly will do.
So my memory is I think it's in the same kind of region. I think it's a little bit less than Doctors of the World. I think we're probably talking under 1,000. I'm sorry, I don't know it off the top of my head.
It's not a memory test. You said in your statement that it's around about 200 clients that you help a year.
Okay.
The third organisation is Canlungen. What is that?
Canlungen is a consortium of organisations that represent Filipino and Southeast Asian organisations across the UK.
And lastly, but not least, MedAct. What organisation is that?
So MedAct is a membership organisation. Most of their members are healthcare professionals, and as an organisation, it works to address, I guess, socioeconomic barriers and health inequalities more generally.
You're representing today a group which very credibly assists migrant workers, members of the migrant community in the United Kingdom. Could you give us some idea, please, of the numbers? What proportion of the UK population, for example, is made up of people born abroad, foreign-born people?
So it's about 15% of the UK population.
And just by way of an overview, what particular issues in terms of vulnerabilities and where they are subject to inequalities and to lack of access to healthcare, does that group of foreign-born people give rise to? What areas and issues and concerns, in very general terms, is your group concerned with on their behalf?
Mm-hmm. Well, I mean, of course, not all migrants in the UK face adverse socioeconomic conditions and low socioeconomic conditions. So to a certain extent, I'm not speaking on behalf of every single migrant in the UK. But the people who access the services for the organisations that I represent, on the whole, well, without exception, it is people who face extremely adverse socioeconomic circumstances. Most face extreme poverty or even destitution. The precarity of their situation is exacerbated by insecure immigration status that often prevents them from working legally, so they end up working in dangerous and exploitative conditions, very, very limited access to housing and accommodation. And also, I think it's important to note this level of discrimination, racism and vilification by media, by press, that the people who we represent, our patients, are also subject to.
You identify in your statement a number of other prevalent characteristics, that is to say, aspects of their life and employment in the United Kingdom, which has given rise to concern generally. Just having a quick look at those, do many of the people whose interests you represent have, for example, chronic mental health issues?
Yes.
Is there a high degree of social isolation, in particular digital exclusion?
Yes. Absolutely.
What is digital exclusion?
Well, when you look at this group, it's sort of like, in a way, a little bit of an unusual form of digital exclusion. I'm generalising here, but like on the whole, because migrants tend to be younger, and they also by default are people who are separated from their country of origin and often separated from family, it's a population that's very reliant on digital communication, and actually is on the whole a very digitally literate population. Where digital exclusion comes in for this group is it's entirely linked to poverty and lack of resources. It's not having enough money to put data on your phone. It's relying on public access open Wi-Fi networks all the time, which of course, when the pandemic happened, closed. So the digital poverty that exists in the first place was enormously exacerbated once public spaces and public Wi-Fi closed down.
Right. And also, does that cohort of people also exhibit high levels of disability?
Yes, that's what the evidence shows.
All right. Now, obviously, one of the sectors that was amongst the sectors most impacted by the pandemic was those persons who work in hospitality, transport, and the health and social care sectors. Are those sectors in which the people whom you represent are, in fact, overrepresented?
Yeah, absolutely disproportionately represented across all of those sectors, and a lot of those are frontline sectors.
And therefore, in the course of the pandemic, their operation and the way in which they were affected by the pandemic, not least because of the fact that many of them kept working in those frontline sectors, were issues which you were directly concerned.
Yeah, exactly.
Let's look for a moment, please, at some of the areas in which you've expressed the greatest concern. Is it fair to say that in a general sense, your statement is quite critical of the United Kingdom government for failing, as you see it, to implement sufficient measures in good time for the protection of the persons whom you represent?
Yes. Our experience on the whole was that we as organisations, it was left to us to identify and raise issues that the people we represented faced accessing a range of COVID services and just ability to protect themselves from the virus. And then when we did, that was not, the issues we raised were not properly considered. We either got no response, often there was no action, either we were often left to identify what solutions would be as well, and even when we proposed solutions, that led to no action. Or, and I think we'll come on to this, is sometimes when there was an attempt to act on the information we were providing, the information we were providing, the attempts to do that ultimately were completely undermined and hamstrung by a set of policies that were in place and remained in place throughout the pandemic.
Well, let's look at what those policies are. Obviously, when dealing with the government, many of the persons whom you represent came up against the operation of the various policies and procedures and processes that the government's put in place for dealing with foreign-born people. So, in essence, immigration policies. Has there been a very significant issue about how immigration policies rub up against public health policies that the government was trying to put into place at the time?
Yes, and I think the key policy to consider and look at here is the NHS, what we call the NHS charging policy. It's the policy to charge people. It's complicated, but people overseas for NHS treatment. It's extremely complex and extremely uncertain for anybody to know if they're going to end up getting charged. But it is applied to migrants living in the UK. It's complicated, it depends on what your immigration status is, but it is applied to migrants who are living in the UK. They're not overseas visitors, they're people who are resident in the UK. And I won't go into the details of it, but I think the key things, like takeaway things to understand about this policy is that its main impact is deterrence. It keeps people who worry it might be applied to them from going anywhere near healthcare services, and it's partially because the risks associated with the policy are high. It's not just that you're going to get a large bill. If the NHS Trust decides they're going to charge you, you'll get a large bill and also 50% fine for accessing that service. It's also that it carries the risk of being reported to the Home Office. And for those who don't, for those of us who aren't migrants and might not understand, being reported to the Home Office runs the risk that you will be put into immigration detention, and for some people it runs the risk that you'll be returned to a country that you fear for your own safety in. So the risk, this is why what we end up seeing is deterrence, is the risk is too high for a lot of people to go anywhere near healthcare services. And then the second point I'd raise is because it's such a complex policy for individuals, it's nigh on impossible before you enter a service to know if you are going to end up being charged or not. Because charges apply to some services, they don't apply to others, they don't apply to public health services. But this isn't a comment about migrant patients, it's about all patients. That generally, people don't understand what type of service they're accessing in the first place. And clinicians always say patients present with symptoms without diagnosis. You might have a good idea of, you might be fairly confident that what you've got is an infectious disease and therefore you're not going to be charged. But you might not be right about that. It still carries risk.
Thank you very much. I'm just going to ask you just to slow down a little bit. We're going quite rapidly through it, and it's quite hard for the stenographer to record it all. The bottom line here is that it obviously differs between nation, and it differs in terms of particular cohorts. But if you're not ordinarily resident in the United Kingdom, if you don't have settled status or citizenship, then you're liable to be charged by the NHS for what are known as secondary or tertiary NHS services. Is that right?
Yeah.
But as a general rule, that liability to being charged for health services doesn't apply to primary care. So, for example, treatment in an A&E department, or for infectious diseases. Is that right? If they're on a list of prescribed diseases.
Yes, primary care is GP, and yes, A&E and infectious disease are both also exempt, yeah.
All right. So with COVID, the testing for COVID and the initial treatment for COVID was exempt from the charging regime, by and large, because it formed part of a primary care service for which migrants would not be liable to pay the NHS. But the problem you've identified is people don't generally understand that. And therefore, there was a terrible fear that if they went anywhere near the NHS, they would end up being reported to the Home Office, or the NHS might ask them about their liability to pay, and that would expose them to the attention of the Home Office. Is that the nub of it?
Yes, that essentially, yeah.
So there are two issues here. One is the complexity of the system by which people may become liable to pay the NHS, and secondly, the link between the NHS and the Home Office.
Exactly, yes.
All right. Did the government take steps, as far as you understand, to try to explain that nobody would be liable to pay the NHS for primary care treatment, for testing or treatment? Or is it your position and the position of your group that those steps didn't go far enough?
I would go as far as saying essentially no steps were taken. There was, before the pandemic, there was already an exemption for the testing, treatment of infectious disease and vaccinations. And essentially, that was in place before the pandemic because it applies to other infectious disease. And that was the situation that remained throughout the pandemic. I would say the one thing that did happen is that a period, I think it was about a month after, I think it was April, about a month after the lockdown, the government translated that information about exemptions for public health and specified that COVID was included within that. They translated it into a number of languages and hosted it on a government website that is not a patient-accessible website. That was the extent of what the government did.
Is it a public website?
It is a public website. It was what was then called the Public Health England Migrant Health Guide, which is a guide for clinicians around best practice with migrant patients.
And the position of your group is that whatever steps the government took to publicise the fact that migrant people were not liable to pay the NHS simply didn't go far enough.
Yes, eventually when there was, I suppose, an attempt to actually get it out into the public more, that was not until February 2021. So it was only once really the vaccine rollout programme came in that there was any serious attempt that actually people needed to receive this information, even though, we'd had the best part of a year of people being at risk and needing to know about the exemption. So it wasn't until then, and at that point, the government briefed the Daily Mail and then a little bit later the BBC. And that was pretty much the extent of it. Those are not places that that's not a thought through attempt to reach migrant communities. Those are not places where migrants in the UK tend to get their information from. So that was the extent.
Did your group carry out research to try to understand the extent to which migrant people avoided even getting healthcare or treatment or testing for COVID as a result of either ignorance as to what the position was concerning liability for payment, or because of a fear that if they engaged with the NHS, their details would be passed on to the Home Office? What level of lack of understanding or fear was there in terms of a willingness to seek healthcare?
Yeah. Right at the beginning of the pandemic, we did a rapid needs assessment, which included migrant communities with it, and that identified the fear around the NHS and the fear of charges as a key barrier to coming forward. And then later on in the pandemic, both MEDACT and the Joint Council for the Welfare of Immigrants, they both carried out separate pieces of research, but they were both essentially surveys of healthcare staff and also of migrants themselves. And they both found, one slightly above, one slightly below, 50% of respondents said that migrants wouldn't go forward to the NHS because of fear of charging and also data sharing.
On the subject of data sharing,
yeah,
in very general terms, the way in which the system worked then was that if a migrant sought healthcare from the NHS for something that, for healthcare that they were obliged to pay for, so secondary or tertiary treatment, and they didn't pay the amount that was owing, was it then open to the NHS service to seek details from the Home Office as to their liability for payment, their immigration status, and essentially start the ball rolling in terms of trying to find out why they hadn't paid what was owing? Is that the nub of it?
It's slightly different.
Please.
So the information flow actually goes the other way. So once an NHS trust has applied charges to somebody, and if they're over £500 and their bill isn't cleared...
Slow down, please, if you can.
The bill isn't cleared within 2 months. The NHS trust is then obliged, through Department of Health guidance, to report the details of this debt and the person who holds the debt to the Home Office. The Home Office then uses that information. It's a primary grounds to refuse certain types of immigration application. So it means for some individuals, having incurred an NHS debt ends up meaning your chances in the future of regularising your status
are reduced. But the first step is taken by the NHS, because it's the NHS who are owed the money. They will take the first step to contact the Home Office to find out what the position is.
Yes. First of all, yes.
Did the government, during the pandemic, announce or say to NHS trusts in England or across the United Kingdom, if persons without settled status or citizenship have sought treatment for COVID or testing for COVID, they will incur no debt, and therefore you have no need to contact the Home Office to find out what the position is with their immigration status, because there is no debt owing, there is no money due to be paid.
That is essentially what Department of Health was relying on. They were relying on and hoping that invoices wouldn't be raised because it's meant COVID services or certain COVID services were meant to be free. And therefore they wouldn't, because an invoice wasn't raised, there would be no debt to pass on to the Home Office. That's what they were relying upon. The extent to which they communicated that to hospitals, I mean, I don't know everything, but everything that I saw that went to NHS Trust was just around reminding them that certain COVID services were exempt and there would be no need to raise bills. I never saw any direct communication to NHS Trusts that reiterated the point about not sharing data or taking particular care not to share data.
But if no money was owed to the NHS, if there was no debt, then there would be nothing for the NHS Trust or the primary service to speak to the Home Office about, because there would be nothing to engage them.
Yes,
right.
Exactly. But could I just outline
Please.
What the problem with that was?
Yes.
Okay, so the NHS charging programme, the way it's applied, errors are really commonplace. We run a specific service supporting people who've been charged for NHS services, and 20% of our cases are just purely that the NHS Trust has charged for a service that should have been free. And one of the reasons it's mistakes are partially because it's immensely complicated for NHS Trust to apply somebody's immigration status over the service. So sometimes it's due to the complexity, but it's also partially due to the fact it's a heavily automated system. Once one NHS Trust has flagged on your record that you've got some type of insecure immigration status, that stays on your record, and any other NHS Trust will see it. And the way that it usually operates is that a role within the finance team will see when somebody has a hospital episode and it's been flagged that they might have insecure immigration status, they will start the ball rolling on issuing letters and generating invoices. So this is not clinicians and public health doctors sitting around and carefully thinking, oh, well, that's a public health service, so don't charge for that. It's high. The default is you get, if you've got one of these flags on your record, the default is you get charged for stuff, and the onus is on you then to demonstrate why the service shouldn't have been charged for, or why you as an individual should have been exempt from it.
And you've referred just now to 20% of your cases being instances in which migrant people were charged for NHS treatment, for which they shouldn't have been charged. Can you tell us how many of those cases related to migrant people being charged for COVID-19 related testing or treatment for which they shouldn't have been charged? Because obviously we're concerned with the vaccination therapeutic and provision of medicine to migrant people in the course of the pandemic.
I can't say within that, and also within that cohort of people, I would say few to none, just because of the time frame from that. That is the report that we published in 2020, so fairly early on in the pandemic. There might have been one or two COVID cases in that cohort. So I can't honestly say about that. But since then, we have seen patients charged for COVID services, charged for services.
Do you mean for long-term health conditions, for example?
Long-term health conditions.
Long COVID or chronic conditions which have resulted from COVID, as opposed to initial treatment in A&E?
Well, I think I've got the point on this issue.
All right.
I think we need to move on.
So the answer is yes. I've even seen an NHS Trust pursue charges for a vaccine. So yes.
In your statement, you say that one of the things that you've campaigned for is for the government to put into place a firewall between the NHS and the Home Office. So it's not enough just to rely upon the government to tell the NHS what to do. Is that an issue which you've raised with the government and you've sought their response as to whether or not such a firewall should be implemented?
Yes, multiple times, and the Health and Social Care Select Committee carried out an inquiry into this in 2018.
All right. The next issue, broad area raised in your statement, concerns the GP registration system. By and large, during the vaccination process, in order to book a vaccination, patients would have to provide an NHS number. And is it the position that many of the people whose interests you represent do not have or have no access to getting an NHS registration number? Is that the problem?
Yes, our patients are routinely refused GP registration, even though they're entitled to it. The vast majority of our work is actually supporting people to get registered with a GP once they've come to us for initial medical care.
And again, was this an issue which was pursued by your group during the course of the pandemic, when it became apparent that there were migrant people who weren't being offered vaccination, or if they wanted vaccination, couldn't get it because they had no NHS registration number?
Yes, right from the beginning of the pandemic, we raised it as a sort of access to healthcare issue, that people need a GP and needed access to a GP. But once it became clear to us that the way the vaccine model, the way access to the vaccine was being organised, and that it was going to be dependent on the national booking system, at that point, we then began to flag the issue about if you don't. So it's important to note with migrants, the only way you're issued an NHS number is by registering with a GP. If you're born in the UK, you get it at birth, but if you're born outside the UK, you have to register with a GP. That's what generates an NHS number for you. And so then we were aware that our patients are largely not, or people just before there are patients, are not registered with a GP. And so therefore they wouldn't have an NHS number. So once we realised the vaccine, the main way people would get to access the vaccine was through the national booking system, and that you had to have an NHS number to be able to use the national booking system, we became aware that our patients were going to be completely excluded from the vaccine rollout.
In very general terms, what steps did the government take to make it known that you could get a vaccine without an NHS number for which you would have had to have been registered with a GP? Was there any kind of announcement made or any publicity given to a solution to this problem?
Yes. So in February 2021, I referred to the fact that the government briefed the Daily Mail, and the Daily Mail then ran a front page story the next day saying vaccine amnesty for migrants. So that was the first step. But at that stage, all of the messaging was about an amnesty, which was quite confusing because we usually associate that with an immigration amnesty. But also, it didn't deal with. It essentially was just saying to people, go along, get the vaccine, and eventually, when the messaging refined slightly because we raised issues about the data sharing issue, the messaging was refined slightly to say there will be no immigration checks. And this goes to the core issue about the fact that the Department of Health had made the decision not to put in place a firewall, actually just to stop sharing information with the Home Office, which meant that, and we raised this a number of times, it meant that they were never able to say there is a guarantee that your information won't be shared. They just said no checks will be carried out at vaccine centres. So that's quite different situations.
Just pausing there. Are you aware of communications sent by the government, probably the DHSC or in England, Public Health England, to vaccination centres, pharmacies, GPs, NHS commissioning trusts, and in the devolved administrations to their own NHS boards, saying it is possible to, and you should be able to offer vaccination without the production of an NHS number?
Yes, NHS England did that. But my point is that didn't reflect what the reality was, is that they were just putting out sentences saying no NHS number needed. But until June 2021, there were eligibility criteria for the vaccine associated with age. And the way that was then managed was that you would go online and book it through the national booking system. That was always the process to make sure that people within the right age cohorts were able to access the vaccine. But people without an NHS number couldn't do that. So essentially the whole just like no NHS number needed, what that basically meant was wait until June until it becomes completely open access.
So what you're saying is, in terms of the minutiae, the detail in which the prioritisation system was operated, difficulties arose in terms of a lack of an NHS number, because in order to be able to get priority status to which they were entitled, they needed that number.
Yeah.
All right.
Yeah.
The next topic which you raise in your statement, again on the subject of prioritisation, is that did you raise with the government your concern that migrants were not given priority status in that first priority one group, first phase group? So, for example, there were a number of categories, not just stratified by age, but by, for example, work in the health and care sector, who were given priority status. Did you advocate for migrant people to be given priority status?
It was never our position that all migrants should be given priority status. That was never our position. There was one more specific point, which was in relation to people who are in the asylum system and are in accommodation provided by the Home Office on account of the fact that they would otherwise be destitute. And that is often hotels. During the pandemic, the government started using military sites, barracks, 26 people in a room sleeping in a barracks together. There were it was that setting where, and it wasn't just us, JCVI and NHS England both put out direction and guidance to local health teams that they could and should be considering asylum, accommodation, destitution settings like that within their local area when they were carrying out the vaccine rollout. And there was guidance from JCVI that homeless accommodation should be considered as part of cohort 6.
Right.
So our point was that asylum accommodation should have been considered as part of cohort 6.
So in essence, there was a particular vulnerability in the context of asylum accommodation that merited priority being given in cohort 6, which was one of the priority phases, obviously number 6. The last area I want to ask you about is this, please. Much of your statement is concerned with the issue of whether or not there are systemic inequalities and pre-existing barriers in the way of migrant people, preventing them from getting access to healthcare services, and in particular COVID. Is this a topic which has long been the concern of your group and which has been raised with the government on a multitude of occasions, to this effect that as a matter of policy, the government needs to do more to try to reduce barriers and prevent discrimination and inequality by focusing more on the specific needs of the people whom you represent? Is that the nub of it?
Yes.
Right.
Yep.
And is that something which you continue to engage the government with?
Yes, absolutely. And I would say it's not just about doing more, it's about highlighting and properly considering the impact of a number of policies that the Department of Health run that deter and prevent people from being able to access NHS services. And I would say the thing that was unique and really brought to focus during the pandemic was how much these policies presented a public health risk. Policies I'm talking about are NHS charging and the data sharing. How much these policies presented a public health risk and put the whole population at risk. Public Health England had continually advised government that these types of policies were a public health risk, but that advice was overlooked before the pandemic and it was overlooked during the pandemic. And I think, if I may, a final point I'd like to just point out is how extraordinary these policies are. The Medicine de Monde network runs clinics like ours all across Europe, and I have a very good idea of healthcare entitlement policy across Europe. The UK is an outlier in terms of the extent to which people are charged and punished for accessing NHS services, and this very interconnected way in which health data is used to support immigration enforcement. It's really important to not view that as an immigration policy, and also not to view that as an essential or even a normal part of a healthcare system.
Ms. Miller, thank you very much. I'm going to have to ask you to leave it there. Obviously, the widest provision of NHS services is outside the scope of this inquiry. We're concerned with vaccination and therapeutics. But that's very helpful. Thank you very much indeed.
Thank you very much indeed, Ms Miller. Thank you for your help.
Thank you.
Very well, we should break now for lunch. I shall turn at 10 to 2. Keith.
My lady, the first witness this afternoon is Sam Smith-Higgins, please, who will be attending online. Thank you.
Are you able to hear me clearly?
I am.
Thank you. If you'd like to repeat the affirmation after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
be the truth,
the whole truth,
and
nothing but the truth.
nothing but the truth.
Thank you.
We've met before, Sam Higgins, so thank you very Miss Smith-Higgins, sorry. So thank you very much indeed for joining us this afternoon.
Can I please apologise for not being there in person?
Oh, don't be daft.
I find it really disrespectful when people don't appear in person, but my husband is going through cancer treatment, daily cancer treatment, and obviously I have to drive him and what have you, so it was just impossible this time. But I do apologise, and thank you for letting me appear remotely.
No apology necessary. I don't consider any kind of disrespect, and I do hope the treatment works.
Thank you. Me too.
Mrs. Smith-Higgins, could I start, please, with some of the formalities? Could you give the inquiry your full name, please?
Sam Smith-Higgins.
Thank you very much. You've kindly provided a witness statement dated the 7th of February 2024, which you've signed. It contains, as is absolutely usual, a statement of truth, declaring to the truth of the facts in your statement. And the reason why you've provided that statement and why you're giving evidence today is that you're one of the co-leaders of Covid-19 Bereaved Families for Justice, Cymru.
That's correct.
Together with Anna Louise Marsh-Rees, whom we had the pleasure of hearing in I think, modules 1 and 2 and 3.
That's correct.
Your group, Mrs. Smith-Higgins, Covid-19 Bereaved Families for Justice, Cymru, originated, I think, as an autonomous group. It separated from the UK group in July 2021. And it's dedicated itself to campaigning for and giving a voice to those bereaved by Covid-19 in Wales. Is that right?
Right.
I think you're the most prominent organisation in Wales involved in the discourse, as you describe it, surrounding the Covid-19 pandemic.
We certainly are.
And could you just say something briefly, please, about your primary aims? You've referred in your witness statement to the fact that there is an urgent and burning and utterly understandable need to understand why decisions were made as they were, and for errors to be acknowledged, recognised and learnt from. Is that a fair summary of the primary aim of your group?
It is, and also to get change. You know, at the moment, COVID and flu are still rampant throughout healthcare settings in Wales. We desperately need change there. We have made change for bereavement services in Wales already. So yeah, we've got many aims.
You, sadly, have been bereaved, and may I ask you, please, about your father? He was 73 when he was admitted into hospital, was he not, in January 2021 for cancer-related reasons. Had he been vaccinated when he went into hospital?
No. So my dad, Phil Smith, was diagnosed just as lockdowns came in. With prostate cancer. 2 consultants wrote on his notes that he had prostate cancer, but he wasn't told for 6 months, by which time the cancer had spread. In January, it was fairly routine for him to be admitted on the 5th of January for treatment to reduce edema. And I knew he would be in for up to 2 weeks. And when he was admitted, I asked there and then if he could have the vaccine, and I was told no. I asked if he could have HEPA filters. No, he couldn't have any of that. And so I kind of knew that he was going to catch COVID within the next 2 weeks. It was, undoubted.
It was rife, of course, at that stage.
It really was. And the vaccinations had started coming out on the 8th of December, and I was a carer for an 85-year-old, my mother as well, and so I expected her to be sort of vaccinated relatively soon. But as December went through, I was tweeting like mad, everybody, MPs, MSs, head of NHS, saying, what is going on? Why hasn't my mother been vaccinated? And it soon became apparent that actually in Wales, they were focusing on the healthcare workers and not the age or the most vulnerable. By the 11th of January, Cardiff and Vale Health Board tweeted that up to date, up to the 11th of January, they had vaccinated 12,300 people, of which 69 were in care homes and only 75 were over 80. The rest were all healthcare workers. So, I'm watching the TV getting angry because I'm seeing people on the TV being vaccinated, healthcare workers. They don't even live in my health board area, having vaccinations just simply because they work for that particular health board.
And of course, your father, who was then 73, wasn't a care home resident. He wasn't over 80, and therefore he wasn't in the first two priority lists for vaccination. But he was vulnerable because he was in a hospital where COVID was rampant.
And this is the point. He was under Velindre Cancer Hospital, which is the cancer trust in Wales, and they didn't introduce testing for their patients until I think they started sending out invitations mid-January. It was all too late. For those 7 weeks from when vaccinations were introduced, its focus was on keeping healthcare workers working. It wasn't about saving lives or saving people like my dad who were going into what was and still is the most likely place you'll catch COVID, which is a hospital in Wales.
And Mrs. Smith-Higgins, he sadly died on the 26th of January. Did you terribly, in fact, receive a letter following his death inviting him to attend for vaccination?
That's correct. Yes. It was all bittersweet. As I say, we knew he was going to catch COVID while he was in there. It was heart unventilated. It was rife in there, and we just knew he was going to get it. And
so is one of the main issues which you've sought to raise on the part of your members and of your group, in perhaps the main issue, judging by your statement, the issue of the pace of vaccine delivery in Wales. So it has a number of aspects. One of them you've touched upon already is whether or not there was a decision or a policy such that allowed health and care workers to be vaccinated in advance of vulnerable or elderly people. And secondly, whether or not the programme for vaccination in Wales delivered vaccination as speedily as was reasonably possible at that time.
Absolutely. Was there a policy for keeping people in work or keeping people alive? Because, vulnerable people weren't being vaccinated. Fit and healthy healthcare workers were being vaccinated. So, what was it? Saving lives or keeping them in work?
You refer also in your statement to another related issue, which is that in January 2021, the Welsh Government sought to stagger the rollout at one stage in order to ensure that the persons who helped with the process of vaccination, such as vaccinators, weren't left with nothing to do. They were concerned about the prospect of delivering so many first doses that they ran out of vaccines to deliver. Is that an issue which your group is concerned about?
Well, it is. The fact that they apparently only had 2 places in Wales where they could store these vaccinations is a huge concern. I don't know what else to say about that, really. It just makes no sense, does it,
Another area, and you've touched upon prioritisation already, is that a number of your members have expressed concern, have they not, about people they know being missed off the prioritisation list as a sector, as a cohort, or members, you also have concerns about members who were on the list. They should have had their vaccination prioritised, but they weren't invited to attend for vaccination.
Yeah, well,
are there a number of people in that category in your group?
Absolutely. And as you'll have come to learn by now through all the modules, data in Wales is appalling. We have a serious issue here with data stats. At the last module, they were trying to identify people by the flavour of their surname as to whether we've a real issue with data in Wales.
And would your group be assisted by hearing evidence on the subject of those persons who suffered from severe asthma and whether or not they were prioritised over those with moderate asthma, whereas in fact anybody suffering from asthma should have been classified as clinically vulnerable and in a particular group for vaccination?
It's a personal concern for me because I am asthmatic and I do use 2 steroid inhalers per day, but I wasn't classed as having a sufficient respiratory problem to be classed as vulnerable. So, yeah, for me, if I'd caught COVID, then I would have been in serious trouble, I'm sure.
A particularly contentious issue, is VCOD, vaccination as a condition of deployment. And you'll be aware, I know, that the English government introduced a policy of mandatory vaccination for care workers in resident care homes in CGQ registered homes. But the other 4 nations, the other home nations, didn't in fact introduce a policy of vaccination as a condition of deployment. Where do your members stand on this issue? Do they regard the non-implementation of such a policy in Wales as a failure, or was the decision not to follow the English lead in having such a policy the right course, do you think?
There's mixed views from our families, and basically what they want is clarification on how our government, having received the exact same information as Westminster government, took a different decision. In Wales, the private care homes were implementing VCARD anyway. So for us, it's clarification on what was the process, what were the thoughts.
In Wales during the pandemic, were you conscious of community pharmacies being properly utilised for the purposes of delivering and rolling out vaccines?
No, again, not at all. As I say, pharmacists had to apply to give out vaccines. It wasn't an automatic thing. There were barriers put in there, and to date, you still don't go through community pharmacies for such things here.
Were there problems, as far as you could tell, with the rollout of vaccines in deprived areas in Wales and also rural areas where obviously there was a great deal more difficulty in terms of the barriers there to getting to a vaccination centre or perhaps getting to a GP or to a community pharmacy?
Absolutely. I live in Cwmbran, and one of the mass vaccination centres was actually here in our town. It was the one that Boris Johnson visited, actually. And even for us, under an Iron Bevan Health Board, the Health Board area is huge. And so, for example, somebody travelling from Ebbw Vale would have to travel in the car for 40 minutes to get to that vaccination centre in Cwmbran. Somebody travelling by bus would have to catch numerous buses, and it would probably take them an hour and a half. Now, for people who've been, shielding for months and months and months, to suddenly have to take an hour and a half journey within the same health board, to then stand outside for an hour and a half queuing to get into a sports centre, it wasn't the best thought out, to be honest.
Your statement also refers to a number of other groups of people who had difficulties in terms of being able to be offered vaccination or to take up the offer of vaccination. Are 2 such groups about whom particular concern has been expressed to you? those suffering from disabilities, disabled people, and also a particular cohort of unpaid carers. Are they two groups of people whose constituent members have often raised their worries to you?
Well, yeah, again, hit the jackpot here because I'm also an unpaid carer. There is no registry of unpaid carers in Wales. There's no register of care homes actually either, but there's no register of unpaid carers. It's really difficult to prove that you're an unpaid carer. I had to fill in a power of attorney to get my GP to believe me that I was actually an unpaid carer. I escorted my mother to get her vaccination. I should have been vaccinated at the same point, really. I believe there was so many of us unpaid carers there with older people taking them in. It just seemed nonsense at the time.
Your statement also refers to concerns expressed by your members about the extent of disinformation and misinformation that was prevalent in Wales. Is that a subject matter or a concern that's widely held in your group, or is that something on the outer margins of their core concerns?
The misinformation, for our families, the vast majority of us was sort of, if you've watched somebody die of COVID, you will take a vaccination to prevent that. We were all of the same sort of thought, get it in our veins. We weren't hesitant in any degree. But that said, in Wales, there is hesitancy, and the approach taken by Welsh Government clearly wasn't good enough, because Muslim Doctors Cymru had to take it upon themselves to go out there and start trying to educate themselves, their own communities with videos and what have you. So there's definitely work to be done there.
Would you like to see the systems for reducing barriers and increasing confidence in vaccines improved in the future?
Yeah, absolutely. As I say, this data is really bad in Wales. In England, you'll have an NHS app with all your information on there, your vaccine history and what have you. We haven't got that here. You can see your last medications you ordered, and possibly with a bit of luck, book an appointment in 4 months' time for a GP. So, our data, we are streets behind where you are in Wales, and that is a barrier. You couldn't do anything electronically to rebook your appointment, for example. You had to call and go through all that process. And it wasn't made easy to have a vaccination in Wales.
All right. Finally, and certainly not least, a vital part of the pandemic story is, of course, the provision of existing and new therapeutics for those who couldn't take vaccines, the immunocompromised, for example, or those whom vaccines would not bring a substantial benefit. Have a significant number of members of your group asked about whether or not the systems for developing and researching, manufacturing and making available new and existing therapeutics were properly operated, that everything was done in essence that could be done in order to make therapeutics available?
Yeah, 100%. And two points to make on that. The time frame for vulnerable people to get their therapeutic, their antivirals, was 5 days. You had to allow 2 days to get the test sent off and get your results back, which left a 3-day window for most people. That was really tight, trying to arrange to get to the place where they would do it. And secondly, my dad was transferred to a COVID ward on the 21st of January. Before he went onto that ward, I said, great, are you going to pump him up with antiviral steroids? Are you going to get him the fittest he can? Oh, we'll see. He didn't have anything until the day before he died. And that's when they gave him dexamethasone. So, you know, for a lot of our families, they didn't receive anything. They were lucky to get oxygen. So, yes, work needs to be done.
Thank you very much for your assistance.
Thank you very much indeed, Smith Higgins. Given all that you've been through and that you're going through, I'm particularly grateful to you for giving us your help. I hope that now you've given this help, I suspect we might be hearing from you again in the future, I don't know. But please just focus on trying to get your husband through the treatment, and we'll keep everything crossed for you.
Thank you very much. And again, my apologies. You know, I would have been there.
I know you would. Thank you.
Thank you.
My lady, the next witness is Ruth O'Rafferty, please.
Could we cut the link to Mrs. Smith Higgins? She's obviously looking for the
stop button.
Is there a red button? I don't know. It's all right. I'm told that it'll be done for you remotely. There we go.
To affirm. No, if you stand, take your affirmation. If you'd like to repeat after me, if you'd like to repeat the affirmation after me, I do solemnly, sincerely, and truly.
I do solemnly, sincerely, and truly
Declare and affirm.
declare and affirm
That the evidence I shall give.
that the evidence I shall give
Shall be the truth.
shall be the truth,
The whole truth.
the whole truth,
And nothing but the truth.
and nothing but the truth.
See, there's some water there for you.
Thank you.
I hope you haven't been waiting too long, Sir Rafferty.
Not at all. It's fine.
Could we start, please, with the formality of inviting you to give your full name?
Yes, my name is Ruth O'Rafferty.
Thank you very much. Thank you for attending today, Mrs. O'Rafferty, and for assisting the inquiry. You've kindly provided what can only be described as very lengthy witness statements, 2 witness statements, in fact. The first one dated August 24, and then much more recently, quite late in the day, a very lengthy, I think a 271-page additional statement. But a great deal of care and time and trouble has obviously gone into the preparation of those documents. Thank you very much for those. You've signed both of them. I'd like to start your evidence, please, Mrs. O'Rafferty, by asking you to tell us something about the Scottish Vaccine Injury Group, whom you represent today. We understand that it was initially formed to apply for core participant status in the Scottish inquiry, not the UK inquiry, but the Scottish inquiry. But perhaps more importantly, to provide tailored support for Scottish people who had suffered an adverse reaction to any of the COVID-19 vaccines. Is that right?
That's correct.
Within your group, do we presume, therefore, that there are people who suffered injury, as well as those who, worse, suffered bereavement following vaccination?
Yes, we have both. The majority suffered vaccine injury.
Can you give, please, the inquiry some idea of the size of the Scottish Vaccine Injury Group? How many interests or how many people are you representing, and how many people are you looking after their interests for?
Currently, just approaching 750 people. We have about 680, I believe, in the Facebook group, and we then have a number of individuals who've joined us for the inquiries, so we just message each other and keep in touch by email.
You've set out in your witness statement, we might have it up on the screen, please. It's INQ 000497102 at paragraph 3, the extremely worthy aims of your group. And I would just like to ask you about some of them. You refer in paragraph 3A to the aim of preparing for the Scottish and UK public inquiries. That's self-evident. And you refer in B to the support and encouragement, to which you've already referred, for those who suffered adverse reactions. And you refer to the Facebook group in C. D, you refer to the sharing of up-to-date information on treatments and therapies. Presumably that's a matter of great importance to the members of your group, because you will be privy, no doubt, necessarily over the passage of time, to much more information and detail on treatments and therapies which you've come across, which you can disseminate to their great assistance.
Exactly. And there's a lot of treatments which would be viewed, I suppose, as alternative treatments like infrared, near-red light panels, hyperbaric oxygen therapy, things that we wouldn't necessarily be recommended on the NHS. And we're part of a global coalition of vaccine injury groups, so we share things with each other globally, which is very useful.
At E, you refer to the aim of seeking to raise awareness of vaccine injury to the public, media, political arena and healthcare system. I referred in my opening, as you probably know, to the public interest in trying to reduce the stigmatisation of which you speak in your witness statements surrounding those who believe themselves to have been injured by a vaccine. Is this aim to raise awareness of vaccine injury there because there are many people who doubt whether in fact the vaccines cause injury, and of course it's a very strongly held view on the part of your members that they have to a large extent been ignored?
Yes.
Is that the nub of this?
Yes. There's been a lot of censorship. In fact, Mark Zuckerman's openly talked about how Facebook removed anything related to vaccine injury. So what we experience when we go into medical appointments are medical professionals who've not seen evidence of vaccine injury in social media or the mainstream media. So we're actually met often with quite a lot of disbelief. And actually, we did a survey in our group to find out how doctors seem to feel about vaccine injury. And 46% of them said, or the 46% of the respondents said, that even though doctors said to them, yes, we think this was the vaccine that caused this, they didn't write it in their medical notes. There's an element of fear there that if you speak out against the vaccines, you're going against the societal or cultural expectations that the vaccines are wonderful.
All right. Is it in part because your members feel that they're not being heard, they're not being listened to, and also that there is a degree of ignorance or suspicion perhaps about the injuries that they've suffered, that you have, as you set out at G, also sought to campaign for specialist funded research and specialist centres so that your members can receive the treatment for the injuries which they believe they've suffered from vaccines?
Yes.
Right.
And in fact, Germany, there are specific units that research vaccine injury and long COVID, both, because there is an overlap in symptoms. And we feel that because these were novel technologies that we used for the vaccines, there will be side effects that maybe will be unexpected. And we're very surprised, actually, that nobody has come to us and said, well, look, you are this wonderful research opportunity that we have to find out what's happening as a result of the vaccines. So,
am I right in saying that this is the first occasion on which a representative from your group has given evidence to obviously a public inquiry, but also
yes.
public by way of a select committee or some sort of organisation?
As far as I know, yes.
Right.
I believe UKCV Family may have spoken to some parliamentary members, but we haven't.
And then the last two subparagraphs, F and H, similarly identify that the aims of the group include trying to signpost people towards help and also setting up the charitable and administrative systems to fund particular treatments that aren't available on the NHS.
Yes.
So that gives us some idea of the aims. Now, in your statements, you have, I should say, and this will come as no surprise to you, I know, raised a vast number of points and issues, spanning the technology of vaccines, the scientific foundations for them, their authorization, their research and development, their delivery, in fact, almost every aspect of vaccination and vaccines. Today, I'd like you, however, to try to help us with expanding on those issues and those concerns that your members hold, with a particular focus on the list of issues, the scope of this inquiry and this module, that there are obviously a all number of points and areas and issues which fall wildly outside the scope of this inquiry. And I don't want to take time looking at those. So in no particular order, but it's a topic that you refer to repeatedly in the course of your statements. You identify that one of the main concerns held by your members is, of course, the integrity of the regulatory system in the United Kingdom, the degree of scrutiny that was brought to bear on the authorization of vaccines, and whether or not the safety processes were properly operated, and in particular, whether they were designed and operated in a way that would bring safety-related concerns, side effects to light. Is that a fair summary of that particular topic?
Yes.
Do your members have particular concerns about the administrative or legal routes by which the vaccines were authorised? You've referred in the statements to the authorisation process under Regulation 174 of the regulations to which I referred yesterday. What is the concern on the part of your members as to whether it was Regulation A or Regulation B or some other legal route that was operated?
I think I will try to answer that question, and I don't think I'm knowledgeable enough to answer it in great detail. But from our perspective, the MHRA and the government faced a very significant challenge, and they put in place some updated regulations to allow them to authorise vaccines under very fast processes. I'm not really quite sure if I understand exactly what your question is, to be honest.
But are they concerned about the particular legal route or administrative route that was deployed? So are they worried that there was this legal process under Regulation 174 that was used, or are they worried about the way in which, in detail and in practice, the MHRA went about deciding whether to authorise vaccines?
I think the latter. And shall I expand on that just now?
Yes, please do.
Okay. So the one of the main things that we are concerned about is that in 2005, there was a parliamentary review into the influence of the pharmaceutical industry on the regulatory process in the United Kingdom. And they made lots of recommendations all those years ago, which still have not been implemented.
All right, we're in danger of veering off already.
Okay, so that provides some context
right.
for what I'm just about to say.
Please continue.
Mm-hmm. So a normal process when a new medication is brought out is that they'll make a mock-up of a medication or a vaccine for a clinical trial, and then once it's been authorised, they will then upscale and produce a product that can be mass-produced, because you can't, the way something's made for a clinical trial, you can't mass-produce it. These particular vaccines are biologics, and there was a research study that's in...
I'm so sorry, I'm going to have to interrupt you there. We don't have the time or the wherewithal to be able to go into some of these topics in this sort of detail. Could I put it another way to you? Mm-hmm. It is the core concern of your members that does it revolve around the system by which, in reality and in practice, the MHRA authorised the vaccines, including whether they properly scrutinised the manufacturing and process systems for the production of those vaccines, whether or not the safety trials were properly conducted, whether or not the clinical process was subject to the same degree of scrutiny as the rollout process. Are those the sorts of issues that they're worried about?
Shall I put it another way?
Yes, please.
Your fellow members feel that they sacrifice safety at the expense to gain the speed?
Yes. Thank you. Yes.
So it's the rolling review issue. It's the overall speed by which authorisation was granted and the degree to which they examined it.
No, we understand the rolling review allowed them to see things a lot sooner, so they were able to scrutinise things much more quickly than they would normally, and we don't have a problem with that. What we have a problem with is the upscaled product. Because these are biologics, and because the process defines the product, if you change any little thing in the manufacture of a biologic, the temperature, the ingredients, where it's made, you can get a different product. And there was concerns raised that whether the upscaled product was comparable to the clinical trial product.
As I've said, the two processes, the one
That's
that
right.
underpinned the clinical research and the one that underpinned the at-scale manufacturing.
Correct.
All right. I think we're clear. From your statement, it appears that there are wider issues raised also by your members about the degree to which the data, the trials, the studies and the statistics were properly scrutinised, whether they were accurate, and whether or not the MHRA had before it all the necessary information they needed to properly make a decision on authorisation.
Yes.
Yes? All right. There's quite a strong scientific edge. There are a lot of scientific issues raised in your statements. A great many paragraphs devote themselves to concerns by your group on the technology underlying vaccines. So, for example, vector-based vaccines, the mRNA technology, the use of lipid nanoparticles, I could go on. Is the scientific technological basis of the vaccines a matter of concern for your members? Or are they concerned about the administrative impact, that is to say, the decision to authorise?
All of the above.
All the above?
Yes.
All right.
These are mRNA vaccines have never before been authorised for use in the public. And because they were brought out in such a massive scale, our concerns are that there wasn't enough vigilance, that doctors were not aware. For example, we had somebody who ended up in hospital paralysed for months. And we discovered that she had the same diagnosis as a condition that appeared in the AstraZeneca trial. Had her doctors known that that had happened during the AstraZeneca trial, the trial was actually paused.
Right. There's a number of, I perfectly understand that you hold those beliefs, but there's a number of assertions or observations made in the course of that answer, which we haven't got time to unpick now. The overarching view, though, is, or the overarching position is, you are worried about the scientific superstructure or underpinning of vaccines and whether or not it was properly understood when it came to authorising their use in the United Kingdom. Is that the heart of it?
Yes, whether the doctors actually understood this was a brand new technology, if they had understood the conditions that had arisen during the clinical trials or not, because had they known, they may have been better prepared to diagnose more quickly,
right.
And then those conditions wouldn't have advanced to the stage they did where there's irreparable damage.
Or they would have been treated perhaps in a different way.
Yes.
Right. Much of your statement is concerned with the separate but no less important issue of public messaging. Mm-hmm. That is to say, informing the public about vaccines, about their benefits, about their risks, and about the specific emerging knowledge about the very rare risks that vaccines might give rise to in a number of different ways. So, were you and are you concerned about the whole patient information leaflet process? Whether or not it gave the public enough information, whether or not they were updated in sufficient time when new data and new understanding came to light, whether or not people, when they received their vaccines, understood that there was a patient information leaflet available which might or might not have the right degree of data. Is that Is
This
that
is
the
correct.
broad area?
A lot of our members were not given a leaflet until after they'd received their vaccination, which means they didn't really have informed consent. They didn't know what they were consenting to. And the leaflets really, we now know the level of damage and the level and breadth of injury that can result.
Well,
and these are not listed in the leaflet.
Right. So your general position is that you believe that there was more injury, more damage, more harm done than was being indicated by the patient and public-facing leaflets and information, both from the MHRA, from the government, and from these public information documents.
Yes, and the doctors rely on the Green Book, for example, and that only mentions myocarditis, thrombosis, and Guillain-Barré syndrome, really. And we have so many more other undoubted vaccine reactions.
Another topic, another important issue is, and raised by your members, is whether or not, despite there not being a formal vaccine as condition of deployment policy in Scotland, Wales and Northern Ireland, that they feel that there's a perception, or that they perceive that people were nevertheless coerced, publicly or privately, into taking vaccines. So is the heart of the concern expressed on this topic whether or not the state, the government, were fair and open in describing the benefits and the risks, so that people could make a decision individually for themselves without feeling they were under a degree of coercion?
Well, we had language even in the speech.
I don't want to go into the detail
okay.
of specific cases, because we can't do anything about specific cases, but is that a proper summary, if you like, of the overarching
the published message was you would take the vaccine to save everyone else, that you were selfish not to, you were responsible not to. And we did have lots of people in our group who were in the medical profession who were coerced. We even had somebody who had emails distributed around their workplace naming and shaming people who hadn't yet had their vaccine.
All right. You understand, of course, that we can't delve into individual cases.
No.
But the overarching point is you're concerned about why it was that some people felt they were being coerced or they were under pressure, and whether or not they were given the right information to be able to make a decision free from coercion.
Yes.
That's the heart of it. All right. The yellow card reporting scheme is obviously a vital part of the safety structures in the United Kingdom. Is that a general topic about which your members have expressed a great deal of concern? In essence, whether or not it properly allowed people to record, to register with the government and the authorities adverse effects which they believe they'd encountered, and also whether or not, going the other route, the yellow card scheme and the MHRA kept people properly informed about the position. Is that the heart of the concern?
A lot of people have never heard of the yellow card when they join the group, to be honest. And then we have people who haven't been able to access the yellow card again. They can't find it. The yellow card scheme is a passive reporting scheme, as you know, so it's reliant on people knowing about it. And the government does, by their own admission, say between 1% and 10% of people actually report to the yellow card.
And it's obviously a scheme whereby members of the public and medics can report. And so your position is that people weren't made properly aware of the availability of the yellow card system to allow them to report.
Yes, although it does say about the yellow card in leaflets. But our experience is that doctors were not reporting to the yellow card, even though they said to us that they felt that the vaccine was responsible. And in fact, the Green Book says that all doctors should, even if they're not sure, they should report it to yellow card, and then MHRA will make the decision whether or not there was a causation there or not. So yes, we feel that the yellow card is not fit for purpose. I know that I asked for a copy of my yellow card, and they put that a lot of my symptoms had been resolved when they haven't. So I don't know where they got that information from.
And finally, another scheme, no less important, but it's one that appears to be of huge concern and worry to members in your group and other groups, I should say, is the vaccine damage payment scheme.
Yes.
Has it been the experience of your members that where they've made applications under the scheme, that they've simply not been dealt with sufficiently speedily or at all, or got a positive response? And no doubt you would argue that the actual terms of the scheme, the preconditions for an award, and it's not a compensatory award, but for an award, are overly onerous and impossible in practice to meet.
Yes. I mean, how can you prove you're 60% disabled when your condition fluctuates from day to day? It's actually the response that I get from group members, overwhelming responses. It's a very traumatic experience to go through. Because a lot of them, I mean, I'm having quite, I'm losing my words here, but a lot of us are neurologically impacted. So we find it difficult to communicate. And we have some people who are so badly injured that they can't actually write. So they're trying to get medical records from here, there, and everywhere, collate it all, and they have to prove causation. I mean, how can a normal layperson do that? It's very traumatic. And then when the results come back, and a lot of them, most of them come back the first time round as rejected, and some of the reasons are utterly ridiculous, to be honest. Somebody was accused that individual members. Okay.
Thank you very much, Mrs. O'Rafferty. If I may say so, you've been a very fine advocate, despite your own words, in the interest of your members. But that gives us a very helpful understanding of where the main points of concern are and the scope of them.
I was about to say something similar. You say that people very often have problems communicating, but thank goodness today you obviously feeling on top form for communication, although I appreciate your condition may change on different days. The thing I was quite particularly interested in was you talked about the research in Germany about both vaccine injury and long COVID. And I've been going through your statement, and don't worry, I will go through it all in some detail before I reach any findings. Again, I have been through it, but I'll go through it again. But I was interested because a lot of the concerns that your members have echo the concerns that long COVID sufferers have. Recognition, of course, being one of the primary ones, and then the kind of support and treatment that you need. So I was quite interested to hear you talk about that research. Anyway, thank you very much indeed for your help. I'm really grateful to you. I hope it hasn't been too difficult getting here and getting home.
Thank you.
Ms. Morris, I understand that you and your team represent this witness and the next one. So would it help if I took the afternoon break now? Okay. It's a bit earlier than we normally do, but just so that Ms. Morris and the team can talk to you before you go. And I shall come back. If I said 20 minutes, Ms. Morris, would that help so you can have a chance to talk properly? Very well. 20 minutes, whatever that is from now.
All rise.
Ms Nelson.
My lady, the next witness is Kate Scott, please.
Repeat after me. I swear by Almighty God.
I swear by Almighty God
That the evidence I shall give.
that the evidence I shall give
Shall be the truth.
shall be the truth,
The whole truth.
the whole truth,
And nothing but the truth.
and nothing but the truth.
Are you okay, Ms Scott?
Yes, thank you.
Ms Scott, could you give your full name to the inquiry, please?
Yeah, Mrs. Kate Scott.
Thank you very much for attending the inquiry today and assisting with the evidence that you're going to give. A few preliminary matters, if I may. I'm going to ask you to keep your voice up. Don't speak too quickly. Speak into the microphone so that the stenographers can make a record of everything you're saying. And if I ask a question that isn't clear, please don't hesitate to ask me to repeat it.
Okay.
You have provided a witness statement on behalf of Vaccine Injured Bereaved UK, or VIB UK, and that is INQ 474371. Are the contents of that statement true to the best of your knowledge and belief?
They are, yes.
Now, I'd like to start, please, by asking you some questions about VIB UK, its aims and membership. You explain in your statement that VIB UK is a UK-wide campaign and support group consisting of individuals and families who have either been severely injured or bereaved as a result of receiving a Covid-19 vaccine. Is that right?
Yeah, that's correct. Everyone in our group has medical confirmation that their injuries or the death of their loved one was caused by the vaccine.
It's fair to say, is it, that one of VIB UK's central aims is to achieve reform of the Vaccine Damage Payment Scheme, or VDPS?
Yeah, that's correct. The scheme is inadequate and inefficient. It offers too little, too late, too few.
And that is something we will come back to in the course of your evidence. You note in your statement that your organisation did not exist before the pandemic and you had to create it. And you say this is a symptom of poor planning on the part of the government, which in your view overlooked the potential for vaccine injury and bereavement.
Yeah, we feel like an uncomfortable truth, and we were made to feel like you were the only ones or you were the unlucky ones and just get on with it. And that's impossible when you're grieving a loved one or your husband's in intensive care in a coma for 4 weeks and 5 days, and there was no one to speak to and there was no one to help us. So we've had to, in the worst circumstances, come together and try and navigate through this as a group.
I think you may be alluding there to your own personal experience, and again, that is something we will come back to and explore with you in more detail. But just staying for the moment, please, with the group itself and its aims. You express your gratitude to the chair in your statement for giving VIB UK core participant status in this module of the inquiry, and I want to emphasise that in making that decision, the inquiry acknowledges the experiences of those who have suffered adverse effects following vaccination and is of the view that this will help to counter the stigmatisation which you speak about in your statement.
Yeah, hopefully.
You stress that VIB UK is not anti-vaccination, but rather pro-fairness. Could you expand on that, please?
Yeah, how can we be anti-vaccination when everyone in our group stepped forward and took a vaccine that the government told us was safe and effective? Everybody in our group is either injured or bereaved as a result of doing so. So by, you cannot be anti-vaccination if you're injured from a vaccine that you took.
You make the point that if there is not a proper system of redress for those who have suffered injury and bereavement, it will fuel vaccine hesitancy in the future.
Yeah,
I think something you want to avoid.
Yeah, 100%. So I think Mr. Keith yesterday stated that it is accepted that vaccines or no medicine is 100% safe and effective. Therefore, there should be a fair compensation scheme, and the government should have planned for that, knowing that if nothing is 100% safe and effective and it's being rolled out to so many people, there would be injuries and there would be deaths, and we should have got the help and support and the financial compensation to be able to continue to live our lives.
Staying with VIB UK and the support that it provides, is it right that it's created its own support group for those who have been injured and bereaved by the vaccines? And if so, what sort of support does it provide?
Yeah, so mainly we're a campaign group campaigning for VDPS reform, but we soon realised that we had no one to talk to who had this shared experience of almost being pushed into the shadows during the pandemic. We're an uncomfortable truth, but we are a truth, and the truth is, for everybody in our group, the vaccine caused serious harm and death. So we just, it's not a formal thing. We have a group WhatsApp. It's people talk about it on it daily. You can ask to speak to people individually, and just a safe place to share your grief or your concerns or your challenges, because there wasn't anywhere. There still isn't anywhere other than that.
Alongside the group chat that you've spoken about and the safe space for people, you talk in your statement about hosting a video call every 6 weeks to offer support and enabling members to work together on campaigning for change.
Yeah, and just to catch up, and we send monthly updates on the work that we've been doing, because it's so difficult and emotionally draining. We're 4 years in now with very little change having happened and very little of our voices being listened to. Some people have to dip in and out because we're also trying to navigate life with disability or life without a loved one.
Could we please have on the screen page 4, paragraph 10 of Mrs. Scott's statement? And here you set out VIB UK's hopes in relation to its participation in the inquiry. We just look at these, please.
Yep.
You asked that it result in 3 key outcomes. First, to highlight the fact of vaccine injury and bereavement. Second, to remove the stigma suffered by those who are vaccine injured or bereaved. And third, to compel the government and pharmaceutical companies to look again at how to deal with the inconvenient fact of vaccine injury and bereavement and the effect it's had on those who have been affected. Is that right?
Yeah.
That can come down from the screen, thank you. We've dealt with the group, its aims, the support that it offers, its membership. You are, of course, a member of that group, and the reason you're a member of the group is because of the experience that your husband Jamie had following vaccination.
Yep.
Could you tell us, please, about the impact on Jamie as well as the impact on you and your family?
I can, yeah. Just one last thing about VBK, though, is that the primary causes of the injuries in our group are vaccine-induced thrombotic thrombocytopenia, VIT, Guillain-Barré syndrome, vasculitis, and more. They're all confirmed conditions, so there's a range of conditions. My husband Jamie had VIT, vaccine-induced thrombotic thrombocytopenia. He is a walking miracle. Every day I'm filled with gratitude that he's still alive, but his brain injury is the size of a credit card. His relationship with me, and mostly his relationship with our children, will never be the same again. And I have this constant conflict of that gratitude with the grief that goes with how different life is, and then the guilt for the others in our group who I know would just want 5 more minutes with their loved one. Jamie is amazing. He was in a coma for 4 weeks and 5 days. He's had significant brain surgery, and he was in rehab for 124 in total. When he came home, he was able to watch our son's nativity, but in a very different way. He's blind in both of his eyes in his upper right quadrant. He'll never drive. He'll never live totally independently. He can't look after our children for long periods of time independently. He can't split and divide his attention. He has no high functioning ability. He has short-term memory loss. He has processing information challenges. He has auditory challenges. He has chronic fatigue. He has severe headaches. He's had over 300 medical appointments since we've been home, and they're ongoing. And just everything is different, from how he responds to situations, to how he shows his emotions, to how he interacts with our children.
I take it from what you've said that he is unable to work.
Yeah, he'll never be able to work again. He had a really high functioning, high stressful, multi-international job that he loved, and he was just as cool as a cucumber. He balanced me out, and now he's got all these new feelings, and he often describes that he can see this video playing in his head and how he should respond and how should things come out, but the bit in between is it all gets muddled. So he's got aphasia, which means that sometimes he can't find or think of the right word, which might mean he calls our children the wrong name, or he'll go upstairs to get something and come down with something completely different, or he'll go to the shop with some support and he'll forget what he's gone to get and come out with different things that don't make up a shopping list that you can't cook anything with. But every day he tries, and it's tiring, and you know, we're grateful that he's alive, but at the moment he doesn't feel like he's living, and he was full of so much life.
Given the impact, is it right that your family and Jamie have made a claim to the vaccine damage payment scheme?
We have, yeah, and it was successful, which is an awful thing to have a phone call to say congratulations. We have confirmed that your injury has been caused by the vaccine and that your husband is 60% or more disabled. That's not the case for everyone in our group. People are rejected on such different disability percentages, which I know we're going to cover. But for Jamie, I think the national average salary is £30,000. He will never work again. He was on much more than that. Our house is based on that. Our lifestyle was based on that. I'm no longer working. I also had a career job, but caring for our children, making sure they get to school safely is my responsibility. Taking Jamie to his appointments is my responsibility. Looking after him in those appointments because he can't process medical information, being his advocate everywhere I go, making sure he's safe, stops me from being able to work full time, and that puts a real stress. I don't think that doing the thing the state asked you should put us at risk of losing our house, or people in our group having to use a food bank, having to move house because they can no longer afford it. That's just extra trauma to what we're already struggling through.
Thank you for sharing your account of vaccine injury and telling us about what happened to Jamie and you and your family.
Thank you.
I'd like to move now to talk about some of the broader issues that you have personal experience of, and which your members are deeply concerned about. And we will start with the vaccine damage payment scheme.
Okay.
You say, and you have said already today, that it is not fit for purpose in your view and has systemic inadequacies and inefficiencies. And it's some of those concerns that you have about the scheme that I'd like to turn to now. The first is the time it takes to process claims. And in your witness statement, you set out some figures you obtained as a result of a Freedom of Information Act request, which show that as of the 3rd of October 2023, there had been 7,544 claims related to COVID-19 vaccines, and only 3,519 claimants had been notified of an outcome. 361 claims had been awaiting a decision for more than 12 months. Of those, 150 claims had been awaiting a decision for more than 18 months.
Yep. And awfully, the data has changed and those numbers are worse. So as of the 30th of November 2024, there's 17,519 claims to the VDPS. Only 194 of those have been notified that they're entitled to the payment. 416 people have been told that they are unsuccessful because although causation is met, they are not, inverted commas, disabled enough. And of that, there's 1,027 people still waiting 12 months later. Within that, 438, 18 months, and 126 are still waiting nearly 3 years later for the outcome of their claim.
What sort of impact is this having on your members, the amount of time they're having to wait for these claims to be processed?
Well, most of them have lost their jobs, so paying mortgages, paying rent, feeding your children, feeding your family. Some people there, Dr. Stephen Wright, he died from VIT, one of the first within our group. His wife has lost his income. She looked after the family and brought up a beautiful household that's now without a daddy and without fair income.
Another issue you raise about the VDPS is the application form and problems encountered by your members when completing the application form. What are those problems?
So Jamie's came back and they reviewed over 3,000 pages of medical data. So I understand that takes time. Originally, you had to print out the form and you could only handwrite the answer. When people first applied, there wasn't even a box to tick that someone had died. So you had to write that yourself and write your own tick box to mark that the person you were claiming for had passed away.
You say that the paper application system and questions are antiquated and inept.
Yep.
Would you like to see reform of the process for making the application?
Yeah, along with the whole scheme. I believe they've made a couple of changes, so there is now a kind tick box to say your loved one has died, and you can fill it out online, but it's not a nice, if anyone's ever had to fill out any of these forms, it's pages long, it's brutal, and if you're grieving or are not used to using computers or having all of that information or having the support of someone, you're just again left to do it on your own. And you can see from how much the numbers have grown that people are still only finding out that there is even this scheme available.
Another aspect of the scheme is the 60% disablement criteria in order to qualify for a payment under the scheme. Could you explain to us the problems that has posed for your members?
A percentage disablement is also somewhat offensive, I feel, but regardless of if it's 10% or 59% or Jamie way over 60% or dead, I guess that's 100% disabled. There's no compensation if you fall below that. We only saw yesterday in the video the consequence of being told, sorry, you're only 55% disabled. It's awful, it's devastating, and then there's nothing for no one to help. Someone in our group was told they were only 20% disabled. It took another year to do the mandatory reversal, and then they were told, oh, actually, you're 90% disabled. Congratulations, here you go. There's other people who are 59% disabled in our group, and only if you've got the strength and will to carry on can you fight that system that is so set against us.
Would you like to see the threshold lowered or some other reform? Have you got any ideas for how it could change?
There's many other schemes across the world. I don't think I'm expert in that, other than saying if you did something that the state was told you was safe and effective and that wasn't the case, then there should be fair and adequate compensation. That's on a sliding scale of the impact. Like Jamie will never work again. So that's £120,000. If the national average salary is £30,000, is gone very, very quickly in a very expensive world.
That is the next thing, in fact, that I was going to come on to, which is the fact that the payment under the scheme is limited to £120,000. What would you like to see change about that?
Again, it's nothing compared to what would be seen through civil or through the courts, and we're always told that it is not a compensation scheme, and yet legal action is costful, stressful, complex, and for many are unable to get legal representation, even though causation has been confirmed. So again, it comes back to this acceptable safety profile. Mainstream media, the government, pharmaceutical companies tell us that we fall within this acceptable safety profile. How many are acceptable? One life? Should that not have been enough to pause and just have a look because there were other options? Or 441 people had VIT, 81 of those died. Not everyone has got access to legal support, and we shouldn't have to do it. There should be a compensation scheme that supports those people who are injured and bereaved.
This is a point that I know it's important for you to make, that it's about what is an acceptable safety profile and what does that mean in terms of the people who are vaccine injured and bereaved, and what sort of scheme should be in place for them. Is that right, that if there is going to be a recognition,
I think it damages future trust in vaccines, that if you are this unlucky number or this rare number, but bearing in mind for our group it's not rare. Statistics are interesting, aren't they? Within our group, 100% of the people in it was not safe and effective. That is the fact within our group, and we have always had the truth on our side, and the truth is for everyone in our group and the others who don't even know about our group yet, the vaccine was not safe and effective. And this was mostly people who were fit and healthy. Jamie didn't take a medicine in his life. He surfed, he ran. We played rugby and football with the children, all things that he's now unable to do and will never be able to do again. We were known as being the couple The last two on the dance floor, and this birthday I danced on my own because he's not able to be in that loud, noisy environment.
Sorry to interrupt, I really am, but I think I'm going to have to stop you because it's really difficult for me venturing into the area of where we're talking about scientific evidence and acceptable safety levels. That's something we'll discuss with the experts, and I'm really sorry, but it's more of a scientific evidence-based as opposed to just the individual circumstances.
No, that's what we're asking. We want you to look at that, and no one has told us what that is, and if it is acceptable, why is there not a fair compensation scheme? I'm not a scientist, but Boris Johnson wrote to me and told me we are not a statistic, we would not be ignored, and all the time all we're told is we're very rare and we are a statistic, and I'm here to say that no, we're not. Our lives are destroyed, and everyone in the audience today who's to support us, so are theirs. It's not just my story. There's many others who have had their voices silenced and told that we are an acceptable safety profile and get on with your life.
At that point, I totally understand. I was just trying to avoid going down the path of analysing at this stage.
Yeah, no, I wasn't trying to do that. Yeah. Thank you.
You deal with a number of points in your statement. We won't have time to go through all of them in great detail now, but I just want to identify some of the other concerns in headline form that you have identified.
Yep.
One of them is around communication about safety issues, and you raised the point that in your view there should have been clearer communication about the risks associated with the vaccines, and that they should have been communicated to healthcare professionals and the public so that people could be on the lookout for the types of symptoms that could arise. Is that right?
Yeah, so earlier action and clearer risk communication, we think, could have saved lives. People within our group called ambulances 3 times to be told it was a migraine. It was only on the 4th, when they were seizing in bed, that they were taken to hospital, and that was because the risk and the framework had not been communicated to everyone. Or you were not allowed to even suggest that vaccines caused injury and bereavement. Posts were removed online of death certificates saying it was misinformation. Accounts were closed, and there was no one to say, hang on a minute, if we know it's going to be that it's accepted that there's risk, there should be a safety process of emotionally and medically supporting these people and helping them afterwards.
Another area of concern for your members is the post-marketing surveillance system in the UK, including the yellow card scheme, and people being aware of that scheme and reporting properly through the scheme. You'd like to see that examined as part of the inquiry, is that right?
Yeah, as far as we can see, nothing happens after you input that data. So Jamie had a yellow card. Many in our group have got yellow cards. No one has ever contacted me about it. No one has followed up. People's have got lost. People's weren't registered. Sheila Ward's husband, Stephen Ward, who died, she had to contact them to say, oh, just to let you know, he's passed away. He died from his condition because no one followed up. And again, in other countries, after only one instance of this particular condition, and there are more confirmed conditions, but for VIT, for example, one instance of it meant that they could pause it and they reviewed it to say, what's happening here? Other countries changed much quicker on what age range was being offered that particular vaccine.
So this is the speed of the regulatory response in the UK to the blood clot safety issue. That's something that you want the inquiry to examine. Is that right?
Yeah, because they have acted quick. Same for Guillain-Barré syndrome. My understanding is the quicker you're helped, the better the outcomes are. So yeah, VIT is my expertise area because that's what happened to Jamie. But there are other conditions that the same. People were not listened to when they said, I think this is because of the vaccine. If they had been, and if medical people were able to get the right pathways in, then people's outcomes could have been better.
You also question whether the yellow card scheme is adequate in that it is a voluntary reporting scheme. Would you like to see some assessment on the part of the inquiry as to whether it is useful to have a mandatory reporting scheme?
Yeah, again, I'm not an expert, but I think it should be mandatory. If I turned up to A&E, they asked mandatory questions of things, and that should have been one of them. You know, have you had a vaccine, which is a foreign thing within your body within a certain amount of time? Because especially for certain conditions like Jamie, there's a time frame that is crucial that it only happens in, and if you catch it quickly, outcomes might have been better. Many people, Zion, Lisa Shaw, might still be with us. We will never know that, but had it been communicated properly, then they might have got the right help and support they needed quicker.
Mrs. Scott, we have gone over a large number of concerns in the course of your evidence, and I want to thank you for the clarity of your answers and for sharing your personal experiences.
Can I just ask one really last quick thing? Is when you speak to all the other experts, the scientists, the pharmaceuticals and the government, is just to remember that we are people, so they can easily omit or not include or not discuss vaccine injury. We know for a fact, I am the fact, these people over here are the fact. It did happen, and they cannot continue to ignore it. Sorry is a strong word, and helping us would make a difference.
Thank you very much indeed, Mrs. Scott. I'm truly sorry to hear about your husband's condition.
Thank you.
It must have been extraordinarily difficult for
It
you,
still
for
is,
him,
yeah.
for the children.
Thank you.
And I do understand your concerns. I may have intervened about one aspect. But that's only because I think that's for expert witnesses. But I do understand your concerns, and certainly the point you make about your human beings. Of course you are.
Yeah.
And I shall be examining the issues that you've raised very carefully.
Thank you, because
So
there's
thank you
children
very
without daddies and children with disabled daddies, and just remember that when they try and pretend that we're not important, we are important, and we're part of this pandemic story.
I do understand.
Thank you.
Thank you very much. Stevenson.
My lady, the next witness is Cameron Malik.
Sincerely and truly.
I do solemnly, sincerely and truly
Declare and affirm.
declare and affirm
That the evidence I shall give.
that the evidence I shall give
Shall be the truth.
shall be the truth.
Can we just pause? I'm sorry. When the oath's being taken, I can't have people moving around. I'm really sorry. The oath is very important. Sorry. Can we start again, please?
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
I hope you're all warned, Mr. Marriott, that you'll be the last witness of the day. I'm sorry if it's taken a long time to get to you.
Not at all.
Please, could you say your full name?
It's Cameron Malik.
Mr. Malik, thank you for attending today to assist the inquiry. Just a few preliminary matters. You've heard it said before, but please speak up into the microphone and take it slowly. You have kindly produced two witness statements for Module 4 of the inquiry. The first is dated the 18th of July 2024, and it is INQ 000474256, a statement on behalf of disabled people's organisations, and a supplementary statement dated the 19th of November 2024, INQ 000474610. Can you confirm that you have read both of those statements recently and that you're satisfied their contents are true?
Yes, I am.
Thank you. I'm going to start with a few background matters about your organisation. Is it right that both of those statements have been prepared in cooperation between 4 disabled people's organisations?
Yes, that's correct.
And those are Disability Rights UK, Inclusion Scotland, Disability Action Northern Ireland and Disability Wales.
That's correct, yeah.
You are the Chief Executive Officer of Disability Rights UK, is that correct? I'll be using shorthand DPO throughout your evidence to refer to disabled people's organisations. In terms of who makes up your membership, you explain in your statement that the DPO used the term disabled people to mean people facing disabling social barriers due to their impairments or conditions regardless of their age. And this includes physical impairments, mental health conditions, hearing difficulties, deafness, visual impairments, learning difficulties and neurodiversity. Is that an accurate representation of the people that you're representing?
Yes, that's correct. We represent all disabled people, yeah.
Can you give the inquiry an idea of the number of disabled people that there are in the UK who may be affected by the issues that we're going to discuss in your evidence?
So in total, the UK population, 23% of the UK population would be seen as disabled people. So we're talking about 14 million individuals.
And between all four DPO, you have a substantial reach across all four nations, a network of partner organisations and individual members. Is that right?
That's correct, yes.
What kind of services do DPO offer? Could you explain that in overview?
Sure. So the four national organisations that I'm representing today and that are part of this group, we would see ourselves as kind of like the second-tier organisations, and we often will have lots of local and regional disabled people's organisations that are members of our organisations, but all of us also have direct contact with individual disabled people as well, and we act as their voice on a national basis, really. In terms of services, it can vary from direct services, such as in Northern Ireland, there's a transport service that's delivered by Disability Action Northern Ireland. Disability Rights UK delivers helplines, so a disabled student helpline, independent living helpline, which are those direct services. But outside of that, it's a lot of advocacy and kind of representation work that we do.
And does that include engagement with government departments on key issues, raising awareness and campaigning in that way?
Yes, I mean, a lot of our advocacy naturally engages with government and governmental bodies.
I'm going to turn now to the key issues affecting your members within what we're looking at in Module 4. First, dealing with the inclusion of disabled people in the development and trials of vaccines and therapeutics. You identify in your statement concerns about gaps in engagement with governments, which, if I might put it this way, left disabled people out of the conversation in terms of trials and development. Can you tell the inquiry about those concerns?
Sure. So I think it's really important to recognise where disabled people are in our society. We're often unseen, unheard. We don't have access to power. We often don't have representation in government, in places where decisions are made, where legislation is written, where guidance is designed. And therefore, those spaces have a complete absence of our lived experience of what it's actually like to live as a disabled person in our country. And so without that knowledge and information, decisions get made, and we often refer to it as ableist thinking. So it's designed by people who don't experience the lives that we do, and therefore design those things as they would see them. They don't walk in our shoes, they don't travel in my wheels, as it were, so they don't experience the barriers that we do. And so hence, we as organisations, we feel it's really imperative that the government has robust engagement systems and mechanisms in place that are ongoing, that they don't just try to create them as and when needed, but are ongoing and long-term as required actually to the UK government by the UNCRPD, of which we're a signatory to that treaty.
And just bring that to apply directly to the trials and development of vaccines and therapeutics. Was it a concern of your organisation that without inclusion in that process, disabled people may have doubts or difficult questions about the safety of vaccines and therapeutics for your members?
Well, absolutely. So there's an inherent levels of uncertainty, mistrust within health systems from a lot of disabled people, just because of the experience that we've had of the system ongoing in our lives. We're often we're often told that others know best for what's best for us, that we're not experts in our own lives and our own conditions that we live with day in, day out. And so our concern was that when in this pandemic, so much emphasis was being put on that the vaccine was our way out of it, that there was no central voice of disabled people in our organisations in the whole complete planning system, from the point of kind of testing to deployment to kind of the whole range of things, really.
If we could move on then to prioritisation decisions for vaccines, part of that deployment system that you talk about, which affected disabled people and the clarity of communication. You point out in terms of representation, advice on prioritisation was issued by the Joint Committee on Vaccination and Immunisation, the JCVI. And you had concerns about the representation of disabled people or their voices within the JCVI and its subcommittees when making prioritisation decisions. What were your concerns there?
Well, our concerns was when they were creating the prioritisation list of how, so they were making decisions based on their medical understanding, but they were taking no account of how someone who had a medical condition, underlying health condition, how they structured their lives that actually would put them at risk of catching the virus and potential worse outcomes. And so therefore, lots of disabled people weren't included in, for example, the clinically extremely vulnerable list, who actually would still have had particularly poor outcomes had they have caught the virus. The fact that over 65s were prioritised, and so therefore all the adult population of disabled people who would potentially be at risk of adverse outcomes were not included in the initial rollout and prioritisation list. So where people were placed within those prioritisation was a concern to us.
Well, perhaps if we could move on to look more closely at that concern now about where people were placed and how their placement was communicated to the disabled community. You point specifically to the membership of cohorts, priority cohorts 4 and 6 within your statement. You make the point that there was no specific priority cohort for disabled people.
No.
That disabled people had to fit in or qualify within other groups. Initially, as you've just explained, high-risk adults under 65 years of age were in Category 6. That was the September 2020 provisional advice published by the JCVI. You point out that captured a lot of disabled people because many were clinically extremely vulnerable and that made them high risk. But the position changed, didn't it? That clinically extremely vulnerable people were then moved to Category 4 at the end of December 2020, whilst others with specific underlying conditions remained in Category 6. So I'm taking us through with some simplifying the changes that happened. What was your concern about those changes that I've described and the ease of understanding for disabled people about which category they fell into?
Sure. So the first thing to say is the CEV list wasn't perfect and certainly wasn't complete because it was expanded later on. But irrespective of that, if I look at myself, I was not included in that list, in any list. So I didn't have my first call up for a vaccine until April 2021. And yet my own medical professional people told me that I was at high risk because of lung capacity. And so if I'd have caught it, I think it's really important to remember that millions of people weren't included in the CEV list, even though that was then prioritised. Outside of that, the communication systems that then told people where they fitted in, what list they were in, when their prioritisation, when they would be called up, was not accessible in itself. The whole communication output from government lacked accessibility on so many levels. And if we just take, for example, the NHS standard on accessible information, which has been in law since 2017, wasn't applied. People were receiving letters that were not in easy read or accessible information. People who, blind people were receiving letters that were telling them something, but they had no access how to read it. And particularly at a time when we were during a lockdown, when the current the support systems that people would have relied on suddenly weren't available to them. So people with learning disabilities, for example, if they're receiving notification by post and it's not an easy read, they can't then interpret what that tells them.
Was it also the case that your own organisation was giving advice to some of those you represent that they would need to go to the GP themselves and between them and the GP work out what category they might fall into and whether they were entitled to a vaccine?
Absolutely. So part of what we took on upon ourselves, both as national organisations and our member organisation was that kind of role to try and help interpret what was being sent to people and what they should do.
I want now to ask you about prioritisation decisions affecting people with learning disabilities. To put this into context, you explain in your statement that the JCVI prioritisation advice at the beginning of December 2020 included people with severe and profound learning disability within Priority Group 6. And that then changed and expanded at the end of February 2021 to include all of those on the GP Learning Disability Register, in addition to some other named conditions. So in other words, initially only people with severe and profound learning disability were included in Priority Cohort 6, and then that definition was expanded. Please, can you explain the concerns that you have about that decision making?
Okay, so I think the first thing to say is people with learning disability don't self-label themselves like that, and so individuals don't think, oh, well, I'm profound and
severe and profound.
Severe and profound, sorry, and mild and moderate. So because people are not identifying as that, they wouldn't know which category they fitted into in the first place. I think there are also issues that there are no registers in places like Scotland for people with learning disabilities, so that couldn't work. And it kind of speaks to what I said earlier about why the JCVI actually chose to go down categorising that way, when there is existing data and known knowledge that people with learning disabilities and those have higher rates of death through health-related issues. And so there's pre-existing data on that, on the kind of mortality rates of people with learning disability, and yet that didn't seem to come into the decision here, and these kind of split groups. And the other thing to say is, while the JCVI expanded the definition, that was only after, people like our organisations writing to them, but also there was the Joe Wiley radio presenter who was high profile and was able to raise the concern that she had about a family member. So those kind of things started to push them, but that's not what it should take.
When you refer to some of the statistics, I think you point out in your statement that your understanding from studies is that individuals with learning disabilities were 3.6 times more likely to die from COVID, but that statistic didn't separate people into those categories of how
no, that's right.
Severe their disability might be. It was for all people
that's correct,
who were within that group. You have also expressed concern in your statement about prioritisation of people with Down syndrome specifically. Could you just tell us what your concerns were there?
So again, it was similar concerns as we had with people with learning disabilities, that those individuals, the risk that they had to worse outcomes from catching the virus were again well known. And again, those individuals were not prioritised. And again, this all comes back to a lack of kind of input from our kind of organisations into the decision-making process.
I'm going to move on now to the issue of unpaid carers and how they were prioritised for vaccination. This is a subject you focused on in your supplementary statement. The timeline here is a relatively complex one, Mr. Malik. We may not have the space to do it justice here, but if I might summarise for context from your statement, was the position that the early, sometimes termed provisional JCVI advice of September 2020 made no reference to unpaid carers. And then there were two versions of advice issued in December at the beginning and then at the end of December 2020, where unpaid carers weren't specifically mentioned in the main text, but they were referred to as a footnote, literally a footnote in the document, in the first instance referring the reader to the Green Book, which contained a list of conditions under which some types of unpaid carers fell, and then secondly as a footnote within the guidance. What were your concerns about the clarity of the JCV advice, which was implemented for unpaid carers? And more than that, what effect did that have on disabled people and their carers?
First thing I would just say is there was a total lack of clarity. In order to put out a prioritisation list that then required you to look in footnotes and open other documents such as green books, I don't know how many members of the general public would even be aware that there is such a thing as a green book. And then to go and try and read something that's written in a language that speaks to a particular type of individual, those kind of scientists, professionals, but not to the general public layperson who might be trying to find out where they fit in within the prioritisation. To expect members of the public to do that, unpaid carers to be doing that, is just not acceptable. The other thing is, again, it comes back to not understanding how disabled people how we structure our lives, and that a lot of us, much more than most kind of data would tell you, rely on the kind of unpaid support of family, of friends, of other systems that we've put in place to provide us with kind of the day-to-day support we need to live our lives. And because that knowledge was not understood, unpaid carers were not part of the kind of the prioritisation, and again required our organisations to be kind of advocating on that point that they should be. The impact for disabled people is that if you yourself are at risk of worse outcomes of catching COVID and you are isolating and you're relying on those unpaid carers who are then not eligible for or not able to get the vaccine, you are at greater risk because those carers don't necessarily live with you, but they would be coming into your space. And so if those individuals are not vaccinated, then you're at risk as well. So it creates a real strain on that individual and their relationship with one another.
Were there also some concerns about the definition itself of unpaid carer in its revised form, that it was a person who was the sole or primary carer of an elderly or disabled person at increased risk of COVID-19 mortality, and therefore clinically vulnerable? Did you have views on whether that properly served the disabled community?
Well, I think that, again, the risk is this idea that it might be your sole or only person that looks after your support, she'll give you some support. You may have multiple people that provide you support through a week. The other kind of confusions around this was there was an expectation that unpaid carers would apply for carers allowance. That's even if they knew about it, because there was certainly no information going out to people to say who is and who isn't able to claim that particular benefit, and also the time lag between knowing about it, applying for it, and a decision being made would have meant that months would have gone by before you'd be eligible.
Ms. Malik, we perhaps don't have time to go into the issue as it stood in every nation, but you point out in your statement that disabled people across the 4 nations experience differences in the definitions of unpaid carers or the practical ways that they were applied and identified. Was that also the case?
Yes, that's right.
I'm going to move on now to the issue of accessibility, but both in terms of communications about vaccines and therapeutics, and also the accessibility of attending for vaccination. You have already mentioned in your evidence, and you report in your statement, instances of disabled people receiving letters regarding vaccination in non-accessible formats. Can you tell us about those issues and the problems that they caused?
Yes, so if you imagine receiving a letter that has a language that you don't fully understand, it's an official letter that you've received, it's got NHS written at the top, and you can't really quite work out what it's about. The anxiety and stress that might cause you, because you don't know how serious it is, if you're supposed to do something or go somewhere or call someone. So if you can't understand a letter that's officially been sent to you during a very difficult period in the country through a pandemic, That's kind of creates extreme anxiety and stress for those individuals. It also means that that person may not then act on anything, may not know what to do with it, particularly if you've got someone with a learning disability, and the letters in kind of standard English or complex English, not in an easy read version or plain English formats. If you're blind and you receive a letter, also, deaf people, English is not their first language. BSL is often the first language. So if you don't have access to all those alternative formats, you won't get the messaging that's coming at you.
And presumably the same goes for booking systems, which need to be accessible in the ways that you've described in terms of plain English, adjusted font, digital and non-digital routes.
Yes, so all of those rules apply, irrespective of the medium that you're choosing to use. Remembering we have a digital divide in the country of those who do and don't have access to internet, web, those kind of technologies, and that is particularly pronounced in disabled people's communities.
You perhaps falls into one of the things that you would recommend or ask the inquiry to consider is that it's really important for the health services responsible for contacting disabled people to have a record of their communication preferences, and in a pandemic scenario for there to be easy access to communication preferences and for those to be used in vaccine booking systems.
It should be the absolute basic. Once you've told the NHS what your preferred communication method is, it should be registered, and everything going out should be in that format.
Not forgetting then, finally on this point, the physical accessibility of going to get a vaccine for disabled people. Can you explain some of the challenges which were experienced and reported to your organisation in attending vaccination centres?
So I think I've put a particular case in my witness statement around Dr. Rupi Kaur, who is someone with 24 hours support and has cerebral palsy and is an electric wheelchair user, was, when looking for vaccination for herself and her carers, was sent to a football stadium in Manchester, the Etihad Stadium, and on arrival her carers found that there was no access for wheelchair users. And yet when looking at the website, that wasn't clearly evident. So that information just isn't front and centre about when you're picking what your access requirements are, the system should be designed to then identify the centres that actually have that accessibility for you, so you're not sent trying to find the right place to go to. And then when trying to kind of tackle that through 111 and the GP, was kind of then accused that you're trying to jump the system, the queue, to try and get priority elsewhere. So kind of accessibility starts at the point of being informed on the web, booking, and having alternative methods. But then when you get there, the location of centres, and then the whole kind of accessibility route of arrival, how near it is to you, if you can drive there, is there parking for wheelchair users or blue badge holders, are there drop-off points? Are you waiting outside in the rain as a wheelchair user? When I went to get my vaccination, I live in North London, but for some reason I was sent to St Thomas's in central London. Now, I'm fortunate I drive, so I drove there on that occasion, but found it difficult to park anywhere. And then I had to wait outside in a huge queue in the rain, in the cold. And so all of these things are just not taken into account. And I think just what I would like to say, what's frustrating for our organisations, is we tell the government this all the time. This is not something new. Disabled people have always been around, and we've been engaging with governments for years, saying the same things over and over again.
Thank you for sharing those experiences. I just want to touch briefly on the point of monitoring and uptake. Is it right that you have concerns about the sufficiency of the type of data captured about disabled people and the ability of such data to reflect any disparities in vaccine uptake? And you point in your statement to the fact that the UK government at times relied on ONS data, which wasn't up to date. It didn't separate types of disability, for example. Would you consider it also one of the key things to come out of your statement that governments need to have data which distinguishes between types of disability, which is up to date, captured in as real time as possible in an emergency scenario, so that groups that might have a lower uptake can be accurately tracked and action can be taken to help them.
Yeah, I would absolutely say that, and it's been systemically an issue that we don't collect that level of data in that way, and relying on 2011 census data that didn't disaggregate the data in that way based on impairments and disability. So you can't monitor, and if you can't monitor it, you can't then take action on the areas that you need to be doing.
And finally, then, the subject of therapeutics and the steps taken to enable their use, including of prophylactics and new drugs amongst disabled people. What were your concerns, please, about that?
So I think looking at it, the priority was solely based on the vaccine programme. Huge amount of investment went into that and not looking at other therapeutics, and particularly when we've got in our nation 1.2 million immunocompromised individuals for whom the vaccine was not a possibility, and they were not able to take that, but that when there was evidence of other therapeutics available that were available in other countries and were showing good rates of success, that we didn't have access to those. And I think our question was why were they not prioritised? Was it because there was other evidence that the government had access to about them not being effective, or was it purely a financial decision?
Would it be right to characterise the DPO's view on the cancellation of the Evusheld contract as one of particular disappointment for you?
Yes, again, because of the success rates that it was showing in other places. Absolutely. And the impact is that those individuals who can't have the vaccine have to continue shielding. While the rest of the country got out and went back to a level of normality, those individuals' lives couldn't change. They had to continue to isolate, but without any of the support systems that may have been available to them during the height of the pandemic.
Ms Malik, thank you very much. Those are all of my questions for you. My ladies, do you have any questions?
Thank you very much, Ms Malik. I find it astonishing that government could ignore an advocate as eloquent as you are. I think I might have described your advocacy as eloquent last time you helped me. You've now helped me twice. I've got a feeling you're going to be helping me again in the future. So thank you very much indeed. You made some very important points, and I'm really grateful to you.
Thank you.
Right, we shall finish now and start again at 10 o'clock tomorrow.
All rise.